morning, everyone, and welcome to the second day of NCI's Global Cancer Stigma Research Workshop. I want to thank everyone who took part in yesterday's sessions for an incredibly rich and thought-provoking day. It was difficult to choose highlights, but a few themes really stood out to me. First, I was so grateful for the patient and survivor perspectives we heard, both in first-person accounts, thanks to Jim and Carolyn, as well as through the quotes, images, and brief narratives of the research participants that a number of the panelists shared with us in their talks. For me, these really illustrate the power of prioritizing the voices of individuals with lived experience and reminded me that there are many ways to incorporate community partners in our work, whether through advocacy, roles on IRBs, panel speakers, community health workers, or even as co-grantees. I was also struck by the idea of shifting our view from the position we often take. This is something that Laura said several times yesterday, which is to place the burden of stigma response on the individual, and instead to a recognition that social forces drive stigma, and as a result, that it is incumbent upon us to recognize and address these larger forces outside of the individual. And finally, as is the case for me, for so many of the great conferences I go to, I left with more questions than answers. And in particular, I was thinking a lot about how do we best assess and address intersectional stigma? How do we think about intervening and addressing self-stigma, family stigma, public stigma, intersectional stigma, all the stigmas we talked about? And then how do we balance the complexity of health behaviors, prevention, stigma, disease, sort of all of them, all of the components we talked about yesterday, because as noted by Jamie Ostroff in her presentation, and I started in my notes, everyone deserves unbiased care. And so today I hope we'll continue and expand many of these conversations, starting with two talks on stigma in a global context. The first is focused on cancer stigma across cultures, and the second is focused on global stigma across health conditions. We'll then turn our attention to interventions, hearing about several specific approaches and considering the implications of this work for our ongoing efforts. And then finally, Dr. Bill Klein has kindly offered to close the day, highlighting the major ideas raised and helping us hopefully begin to integrate the many topics and directions discussed. As a reminder, for housekeeping, please turn off your cameras and mute your microphones during speaker presentations. And please also turn on your cameras if you would like during the Q&A portions of the day. I think that worked really nicely yesterday when people did that. Please continue to hold all questions until the end of speaker presentations or put them in the chat. And finally, we found that the chat box was a really great tool yesterday, serving as a way to collect questions and share resources and really deepen the points that people were making in the ongoing conversation. So please continue to use the feature for these purposes today. Okay, with that, I'm excited to introduce the first speaker of the day, Dr. Sonali Johnson. Dr. Johnson is Head of Knowledge, Advocacy, and Policy at the Union for International Cancer Control. Her main area of work is to ensure that cancer prevention, treatment, and care is positioned within a global health and development agenda. Dr. Johnson has worked on a range of public health issues, including cancer control, and has twice served as a member of the Ethics Review Committee of the World Health Organization. We're so happy you're here, Dr. Johnson. You can go ahead.
Thank you so much, Katie. It's really great to be here. Hello, everyone. Hello from Geneva. So it's afternoon my time, morning your time, so good morning. Yes, my name is Sonali Johnson, and I'm working for the Union International Cancer Control, who I'm sure you know, we're a membership organization based in more than 170 countries. I'm just going to share my screen. I hope this comes up.
That's great.
Can you see it? 1 minute. Can you see?
Yep, we see the speaker, your view.
Okay, I'm going to just stop my video and I'm going to start now.
Okay, great.
Great. So my talk today is titled Myths, Misconceptions, and Cancer Stigma. So ahead of that, I hope there's not too much duplication with what has happened, what has been discussed yesterday. But I'm just going to outline how I will be presenting my talk today. I will talk a little bit about conceptualizing stigma, and excuse me, as I said, for the repetition, but I think I just want to ground it a little bit in the definitions I'm using. Then I'll talk about cancer as a social phenomenon, addressing cancer stigma, the key drivers of stigma, the impact of stigma, cancer and awareness, what steps can we take now? And then adding to the whole pot of research questions, I have certainly my own research questions. So Canadian sociologist Irving Goffman's seminal work on stigma in the 1960s set out the social and psychological dimensions of stigma, which Goffman defined as an attribute that is deeply discrediting and where stigma causes an individual to be mentally classified by others in an undesirable, rejected stereotype. And since then, sociologists and psychologists have examined the drivers and presentation of stigma, looking at status loss, discrimination, and its impact on mental health, and in relation to the lived experience of people with health conditions such as disability, mental health conditions, HIV/AIDS, and cancer, as well as looking at how stigma operates at the micro, the meso, and the macro societal population levels. About cancer stigma in literature and from cancer patients in different countries, and certainly what Carolyn Taylor had talked about yesterday in her talk on the global face of stigma, cancer is a stigmatized disease around the world. And in fact, one of our members from the Ivory Coast, the Côte d'Ivoire, told us that there isn't even a word for cancer in her language. People with cancer are differentiated or set apart from people who don't have cancer, which is part of this spoiled identity that Goffman uses to describe as a central function of stigma. Phenomenon. It is more than a medical issue, but one that has strong social dimension. It's socially constructed with strong imagery in public consciousness. I think all of us have seen the words cancer used in situations which are not linked to the medical diagnosis of cancer. When I talk about some languages, particularly English, I'll concentrate on English here. We use strong metaphors in relation to cancer. For example, the word cancer is used to describe something that's rotten, the cancer of racism, something that's pervasive, malignant in society. We also use words related to war and conflict, war metaphors when we talk about cancer. And that is often in conferences or even in the media, battle against cancer, fight against cancer, war against cancer. And the cancer is presented as the enemy, cancer patient as heroic. I mean, somewhat unsurprisingly, there are growing calls to stop using these battlefield terms and metaphors in relation to cancer. Here I've put two such headlines from newspapers. One says, "War on Cancer, Metaphors May Do Harm, Research Shows." That's from The Guardian from a few years ago. "Stop Calling Cancer a Battle," experts say, comes from a lifestyle site, which is a news and lifestyle site from New Zealand. And at UICC, we've been looking at this because we have Fighting Cancer Together in our tagline, and we've been discussing internally about, really not using these sort of terminology to perpetuate this sort of harmful language. And actually in other communities like HIV/AIDS, and one of our staff members has come from the HIV/AIDS community to us and was surprised to see the language here and told us at a recent meeting, we really don't use these words. So I think something that we need to think about is how we talk about cancer publicly, how we talk about cancer in our communications. UICC has been looking at stigma for a number of years. One of the main functions of our World Cancer Day, held every 4th of February, is to promote positive messages about cancer. What can we do to prevent and treat it? How can we better support cancer patients and their families? And World Cancer Day really promotes engagement with the public and with governments in the broader community to make progress in relation to cancer. And then we have Target 5 of our World Cancer Declaration, which is on reducing stigma and dispelling myths about cancer. But let's look at the dimensions of stigma that we need to address as a cancer community. Some questions that I certainly have been interested in understanding include, to what extent is stigma context specific? How do we shape the solutions to the problem of stigma? Firstly, the available literature on stigma and the testimonies of cancer patients, survivors, and representatives from cancer societies point to a universality of cancer stigma. And what do I mean by this? Well, while there are aspects to the lived experience of cancer that are shaped by contextual considerations, culture, background, income status, and other social determinants, there is a commonality of human experience and emotions when it comes to cancer. We are quintessentially human. The human emotions of fear, concern, shame, guilt, embarrassment, uncertainty about the future, not wanting to be pitied. In key informant interviews that I have undertaken, and so have my colleagues, these themes come out again and again. So these seem to be experienced for all cancer sites. And the stigma is shaped by myths and misconceptions around cancer in wider society and then internalized. A key issue related to stigma, which we have found, emerges strongly in the testimonies of cancer patients, and that stigma is meaningfully shaped by the burden of cancer in the country, whether there are services and treatment available, and critically, the survival rate for cancer. In other words, the existence of cancer survivors. And this came up yesterday. In some contexts, people may not even know anyone who has survived cancer. Literature, UICC's reports and testimonies on this topic, and additional interviews I conducted with a small group of key informants from Morocco, Indonesia, Lebanon, Jordan, and Burkina Faso, identify some of the key drivers of stigma. And I just want to point out that this is not part of a structured primary research study, but I do hope that it offers some insight into the representation of stigma and its dimensions that can be further explored and feed into proposed research that the NCI and others are planning to do on this critical topic. So here are some of the key drivers of stigma that emerged in the literature and in the testimonies of people living with cancer. And where possible, I've used illustrative quotes from their narratives. Firstly, a key driver of stigma is the fear of cancer itself. Poor survival due to limited cancer control programs and infrastructure and available treatment, particularly in low-income countries, creates a high sense of fatalism related to a cancer diagnosis. Where a country is in its approach to cancer control, the services and programs it has in place may exert an important influence on the public perception of cancer, which then shapes attitudes towards cancer patients. So here we can see when a country does not have cancer care, and when people see others with cancer walking vertically into hospital and coming out horizontally, then cancer is seen as a fatal disease. That's the mother of a cancer patient speaking, who's a cancer advocate in Jordan. Anyone would have a fear of cancer if they lived in a place where everyone who had cancer died. It's a CML patient and cancer advocate from Morocco. To go to a hospital for cancer means bad news with no means to do anything about it. A cancer surgeon and advocate from Burkina Faso. Then there are the stations of cancer treatment, which can be stigmatizing when perceived by others as disfiguring, as part of the spoiled identity, setting a person apart from the norm and identifies a person as having cancer. And this includes hair loss, fertility issues, extreme weight loss, mastectomy, and other side effects of treatment. So one CML patient and advocate in Morocco said, one woman who had her breast removed told me, I didn't see my breast and my husband. I lost both at the same time. In the playground, children say to the child of a cancer patient, your mummy is bald. Cancer Society representative from Lebanon. When cancers are linked to preventable risk factors or behavior causes such as smoking, drinking, or sexual interaction, the cancer can be stigmatized as being deserved or self-induced, resulting in feelings of shame, guilt, or the social isolation of patients. So one person I spoke to from Indonesia, a cancer patient in remission from endometrial cancer, said, if you're a smoker, you are blamed for your lung cancer. If you're obese, they say it's because of that. Another driver of stigma is the extent to which cancer can be hidden from others. People with money travel abroad for their care, for example, someone from Burkina Faso said. So it's really this concealability of a cancer diagnosis. People who can afford it have reconstructive surgery, said a cancer advocate from Jordan. And there may be a strong financial dimension to this, where people with more resources are able to conceal their diagnosis more easily. For example, they can pay for reconstructive surgery or travel abroad for care. Another driver of stigma is the extent to which cancer interrupts social life and communication with others, i.e. its disruptiveness. Cancer patients do mention that during treatment, they may not feel like participating in social life. Life kind of stops for a while. But when they are feeling better, they receive less invitations to family or work events. And they say that the sentiment behind this may be well-meaning, but it also contributes to feelings of isolation. So here we have from Morocco, no work, no invitations to social events. We are deprived in one go of a human life. Other sentiments expressed by patients included, people don't know what to say to you. They don't know how to talk to you anymore. I don't want to be pitied, so I don't like to see people. People stop including you in things. In other words, highlighting difficulties in communication. Patients and advocates frequently raise the misconception of cancer as contagious, the myth of contagion, which contributes to stigma and the social isolation of not just the person affected, but sometimes the entire family. So, for example, we hear from the Cancer Society representative of Lebanon, children are told not to play with children with cancer to avoid getting it too. Or from Morocco, men don't want to have sexual relations with their wives because of the fear of contagion. Another dimension of the cancer as contagion stigma is the notion of the hereditary nature of cancer. And while a small proportion of cases are hereditary, the concern about cancer being passed on through the generations affects women's marriage prospects, where this has been reported particularly for breast cancer. And this misconception is related to the next two drivers, the fear of the repercussions of cancer. Here, the concern about one's prospects long-term following a cancer diagnosis was mentioned by all of the interviewees in the context of their work with cancer patients. One person spoke that in some communities in her country, there is the notion that bad luck has fallen on the family, or that a person has been cursed or a victim of black magic. Another person mentioned, as you can see from the quote, that cancer patients and survivors worry about how they are seen long-term and what this means for their employment and career. In adolescents, for example, the potential impact on fertility causes concern that they may be seen as less desirable partners, particularly in countries where marriage and children are important markers of status. And as we heard yesterday, in adolescents and adults from the LGBTQ community, there is the challenge of managing stigma related to multiple intersecting identities that can be overwhelming when battling discrimination and ignorance on several fronts. So for many people, in order to avoid real or even perceived repercussions from a cancer diagnosis, cancer may be hidden from others, thereby causing significant mental anxiety and stress. What came out very strong, particularly in the interviews, are the strong gender dimensions related to cancer stigma. For women, interviewees talked about the symbols of femininity being diminished or erased entirely by cancer, as well as the power dynamics of decision-making in patriarchal societies. So you can see some of these quotes. As our cancer patient and advocate said from Morocco, women are abandoned by their husbands and lose their jobs. If you work in an industry where you're supposed to be beautiful, like in a boutique, you cannot work when you have no hair and no eyebrows. And then on decision-making is done by men. A husband can push the treatment of his wife according to his preferences. Heterosexual women's prospects on the marriage market can be diminished, and several UICC members, particularly in the Middle East region, have talked about women worrying about finding marriage partners for their daughters or sisters. But the gender dimensions of stigma, of course, also apply to men. I know that there has been an in-depth discussion of gender yesterday at the workshop. So this is again to highlight the impact of gender norms, values, and assumptions on men's experience of cancer stigma. Here with regard to prostate cancer, a patient advocate from Morocco said, prostate cancer carries stigma because it touches a man's virility. He may feel diminished in front of his friends and colleagues. And then, as I mentioned earlier, the impact of gender norms and inequalities affects the stigma experienced by LGBTQ communities, with a recent study undertaken by researchers at Boston University in the US, finding that sexual minority survivors of either gender significantly differed from heterosexual men and women on each of the 3 quality of life measures, reporting worse physical and mental quality of life and greater difficulty concentrating. The impact of stigma. This point has come up yesterday, but make it again. We really do need more research on the impact of stigma, and we need to be looking at the impact on different groups of people and in international settings. There are gaps in our knowledge, but from available studies and anecdotal accounts, stigma can impact health-seeking behavior where people don't want to know. And I did hear several times the view that our advocates have to contend with it, which is, why should we know about cancer early? It will only disrupt our lives. And this contributes to the problem of late stage diagnosis, particularly in lower and lower middle income country settings. And then there is the quality of life, the psychosocial functioning and mental health of cancer patients. But here is the investment in cancer services over the long term. What do I mean by this? What I mean is that there may be an impact on how agential or willing governments feel in tackling cancer. It may seem like the inverse, right? If there's a growing cancer burden, then governments want to do something about it, but not necessarily. Many countries don't have functioning cancer registries. The extent of cancer is hidden. And there are also misconceptions about the cost, efficacy, and impact of cancer interventions. I mean, we sometimes hear in policy discussions views that point towards cancer is too complicated, too expensive to address. Or as one health representative from a country mission here in Geneva told me, you always want us to do screening, it's too expensive. And then we really need research on the impact of stigma on cancer outcomes. There are studies looking at screening attendance and late stage diagnosis, but we can also look at issues such as stigma and treatment abandonment, across cancer sites. So I think these are some impact areas to discuss. And certainly when we look at the policy level intervention, we already go ready to country missions and government representatives with cost-effective investment cases to say, look, this is what you can do in this level of resources to kind of try to diminish that misconception that cancer is just too difficult and complicated to do. 10 years, UICC and its membership has been looking to address stigma through promoting evidence-informed, verified information about cancer. We recognize that this is only part of the story, as there are many intersectional issues. However, our members frequently refer to the importance of advocacy and communication about cancer. What causes cancer? How can it be detected and diagnosed and treated? Also emphasizing the importance of palliative care, human rights, and legislation against discrimination. In 2019, UICC commissioned an international survey on public perceptions around cancer. It's one of the few multi-country studies to have been conducted into this issue. More than 15,000 adults across 20 countries were surveyed online from the 25th October, 25th November in 2019, providing an important insight into public attitudes around cancer in several countries. And you can see these countries listed here. Respondents were asked 5 questions related to their concern about cancer, its impact on themselves and their family, their perceptions of risk factors, and their personal attitudes and behavior, together with the expectations of their governments. Over 3 in 5 people surveyed said that they have been affected by cancer in some way, and over half said they are concerned about developing cancer in the future. 7 out of 10 people surveyed, 69%, indicated that they have taken some steps to reduce their risk of cancer in the past 12 months. And the most common action they took, highlighted by 1 in 3 individuals, is increasing the consumption of healthy food. Encouragingly, most people surveyed are aware of at least one of the main cancer risk factors. And approximately 1/3 of the people indicated the belief that the most important governmental measure is to make cancer services more affordable. Irrespective of where people live in the world, those surveyed with a lower level of education and those on lower incomes appeared less aware of the main risk factors associated with cancer, with the exception of tobacco use, which was equally recognized as a cancer risk factor, regardless of income level. However, those with lower levels of education and less income appeared less likely to proactively take the steps needed to reduce their cancer risk than those from a high-income household or with a university education. So this really points towards the need for a focus on equity and promoting health for all. When it comes to the issue of concern, what we found is that people's reasons for being concerned about cancer are varied, complex, and layered. A person's own experience with cancer, their family history, their level of awareness, their understanding of the disease, and other reasons largely unknown to us contribute to their overall sense of concern. Compared to upper middle and lower middle income country classifications, individuals in higher income countries appear to be less concerned about cancer. And the question for us is therefore whether high income countries, which tend to have stronger health care systems, include universal health coverage, relatively high access to treatment and care, and a sufficient healthcare workforce and better survival rates engender more confidence in the population and therefore a less concerned population. And the question to this is not clear, but we do need more research to look at the manifestation and dimensions of stigma over time. So interesting, if you look at this, you can see that Kenya is the most concerned country compared to Saudi Arabia and Sweden, and they are the only two countries where the number of people surveyed expressed a lower level of concern exceeds those who express more concern. My last few slides I'll go through quickly, but I just want to highlight this one. What's really encouraging is that an overwhelming 84% of individuals, the vast majority of people, believe that their government should do something about cancer. And this really gives us a great opportunity for health promotion and to take concrete steps to counter myths and misconceptions and tackle cancer stigma. And as I mentioned before, approximately a third of people indicate the belief that the most important governmental measure is to make cancer services more affordable. So what steps do we need to take now? Well, we believe that it's important to address cancer stigma as part of a country's national cancer control plan. It's important to promote the visibility of cancer patients and survivors in the community in a positive way. Many of our members do organize activities with survivors, with the public. For example, organizing flash mobs with patients to show that you can still enjoy yourself while living with cancer. And the voices of cancer patients, whether newly diagnosed, undergoing treatment, or in remission or recovered, is important to shaping societal understanding of cancer by encouraging greater awareness of risk factors, diagnosis, and management, and dispelling myths and misconceptions. Countering misinformation. Misinformation in the public domain is a problem. And people then make their own assumptions. For example, one of the interviewees talked about patients she works with dieting while on cancer treatment or taking unapproved, unregulated alternative medicines. And as a cancer control community, we really need to look at ways to counter misinformation through campaigns, through social media and other platforms. Invest in cancer services and improving cancer outcomes. It's critical to improve cancer infrastructure, particularly in LMIC countries with late diagnosis and poorer outcomes, thus compounding the stigma of cancer as a fatal disease. There's a high-level meeting next year on universal health coverage, and it's important for us to advocate with governments about the importance of including cancer services on a progressive basis within national UHC plans. Health workers, including GPs, need to be trained in cancer as they're not always aware of the advances in treatment or about side effects or the importance of early diagnosis, and of course, the importance of strong interpersonal communication. Psycho-oncology services, including counseling, education, and peer support groups, can provide an outlet for cancer patients to discuss their experience of cancer, learn coping techniques, connect with others, and find information and support. Here, cancer civil society organizations are critical. Improve health insurance and put in place anti-discrimination legislation that, for example, covers employment protection, parental leave for children, the parents of children with cancer, and we need to collect more data. So finally, I will end just with some research questions that I certainly have. And these include, do we need to look at cancer stigma along a time continuum? Has stigma improved over time? If so, where and why? How do misconceptions and stigma related to cancer affect health-seeking behavior and cancer outcomes? How do we measure stigma in different contexts using both qualitative and quantitative techniques to ensure we are asking the right questions? How do we approach the intersectionality of stigma with the social determinants of health and find solutions to improve equity? Thanks very much.
Thank you so much, Dr. Johnson. That was, Robin said it perfectly. That was a perfect presentation to start day 2. I feel like you brought so many things together and really expanded the ideas. So I know we're right at time. There's one question, so I'm going to ask it, so you have a minute to answer it. So the question is, does not seeing enough survivors and fatalism contribute to increased stigma in LMICs as opposed to HICs? And so just this idea of visibility, which you spoke to, and how that might differ by context.
So I think a lot of evidence points to that. And I think, I feel fairly confident hypothesizing that, but I think we do need more research on that. If you look at our our international perspective study, it's interesting which countries are very concerned around cancer, you know, and looking at the outcomes in that country versus other countries that are less concerned, Sweden, Saudi Arabia, for example, that have a strong cancer control response, services available, better outcomes. It comes out a lot in interviews talking with cancer advocates in countries. And I think any of my colleagues who are working with cancer patients really would emphasize that when you don't see cancer survivors, then you just think, well, this is it. And that quote from the person I talked to from Jordan, I think really summarizes it. You see people going to hospital vertically and coming out horizontally. Of course, you think that this is the end of your life.
Yeah. No, that was incredibly powerful. That quote stood out to me as well. So it looks like you have started another rich conversation in the chat. So I think we can continue that there. And thank you so much. That was wonderful. We really are very grateful you're here today.
Thank you.
So now we're going to turn to our next speaker, and that is Dr. Lawrence Yang. Larry, are you here?
I am.
Oh, I'm so happy you're here. Okay, let me do your introduction. And we're so excited. I hope I'm not oversharing, but Larry has a second baby on the way. So he's made the time, he's here, and we're so happy he's here because you just kind of never know in that situation. So Dr. Lawrence Yang is a professor and vice chair of the Department of Social and Behavioral Sciences at NYU School of Global Public Health. Dr. Yang is the founding director of the Global Mental Health and Stigma Program, as well as the associate director for the university-wide Global Center for Implementation Science at NYU. Dr. Yang's research focuses on two main areas. The first is stigma, global mental health, and implementation science. And the second is cognition of untreated psychosis. Within his stigma portfolio, Dr. Yang conducts research focusing on addressing the stigma of health conditions, as well as theoretical work on how culture relates to stigma. And again, we're so happy you're here, and I will turn off my camera and let you get started.
Thanks, Katie. I really appreciate it, and thanks for sharing. Yeah, I'm glad to be joining here. My son-to-be is, has cooperated to make it so. So I tweaked my title just a bit to focus on measuring stigma of health conditions in the global context. What matters most: perspective and applications to cancer stigma. And you'll see why I did that in just a bit. So I'm meeting many of you for the first time. I'm really excited to be invited to this workshop. I am a newcomer to the cancer field and the cancer stigma field. And so I just thought I'd, highlight a couple things about my background that really illuminate the perspective that I'm going to be bringing to the talk today. So I've been in the area of mental illness stigma for about 2 decades. And with a particular focus on culture, which I've been looking at since my K Award about 2 decades ago. And so I'm very excited to bring that work, over to this area now. More recently, I've done work in the stigma of HIV, opioids, and now cancer. I am one of the supplement awardees, and thank you so much, NCI, for the support. Early on in my career as well, I had a chance as a postdoc to work with Bruce Link, a long-term mentor of mine, and we wrote this Measuring Mental Illness Stigma Review that was sponsored by NIH. I have in red here, you can see the 123 studies, and I have that highlighted because I was the postdoc, so I read all those studies. But it all paid off because 12 years later, I got to then lead author the National Academy of Sciences publication on measuring mental illness stigma, again, in mental illness. So I'm going to be drawing from just that knowledge as I go through today's talk. And then I've also done a number of stigma interventions that are typically incorporate peers. So let me give you an overview of today's talk. I'm very excited. Dr. Gopal and others talked about how this is a real opportunity in terms of cancer stigma measures, gaps and new opportunities, and outlining discussion points to move forward. And so, in the spirit of that, I'm gonna pose a big question. So, how can new cancer stigma scales best capture the dimensions of the lived experience of cancer and LMIC? And I have some thoughts on that. I also want to touch on some points that I, don't have actually. I think it's just these are points for future discussion. I just, as a newcomer to the cancer stigma field, just things that I've observed in preparing for today's talk that it would just be great, for us to think more about as the field progresses. So how do we balance an emphasis on stigma of general health conditions, which there's been a push towards, versus disease specific, so cancer stigma? And then there's also been a proliferation of cancer subtypes, stigma scales. So where should ought the balance to be, in the development of future scale? And then I'm going to talk quite a bit about standardized versus culturally tailored approaches for LMIC. Pulling from my own work, global applications of what matters most in stigma, and I'll be illustrating that from my work in Botswana and also in Vietnam. So in terms of the first item around health-related stigma, this has been a real push from actually NIH sponsored to identify commonalities across major stigmatized conditions. And this includes looking at cross-cutting stigma from infectious diseases, non-infectious chronic conditions, including cancer and mental health conditions. And so there have been a number of concepts that have been shown to be cross-cutting. So for instance, for public stigma, social distance, we're all familiar with that concept. For self-stigma, there's been actually quite a reliance, for instance, on HIV stigma, so Berger stigma scale, as well as the ISMI, the internalized stigma of mental illness, another internalized stigma scale. So although these should be cross-cutting forms of stigma, there's been a reliance on preceding stigma scales because mental illness and HIV have had the longest histories. There are also cross-cutting methods to intervene with stigma that have been identified. These include psychoeducation. Many speakers talked about that, as well as peer-led types of intervention. Moving to cancer stigma scales, I actually, just one note, I think that the cancer stigma scales that I've seen at least draw quite nicely, I think quite well from the overarching stigma of health conditions literature. So there are stigma of general cancer. In terms of public stigma scales, these include things like the Cancer Stigma Scale, widely used. Some talks spoke about this yesterday, Cancer Stigma Index. And then moving to self-stigma scales, there are a lot of scales for different forms of cancer, so cancer subtypes. Interestingly, and this is again an observation from the outside, I found it really interesting that there's stigma related to financial concerns, particularly cancer, and that just stood out to me. That isn't a typical part for other disease conditions. So it's interesting just to note that. And then for different cancer subtypes, there's a strong argument to create new scales for different subtypes because there are different features. So for instance, for lung and cervical cancer, blame and blameworthiness, we talked about this, head and neck cancer, shame and disfigurement would be things that jump out. So let's just talk, I'm just gonna talk about a couple exemplar scales and then make a couple observations that, again, just my, gloss of the literature, to give you my viewpoint. So in terms of a public stigma scale, the Cancer Stigma Scale is a widely used one. This was developed in the general public in the UK. It's translated into other languages based on a social psychological stigma framework. It's a great framework, Jones et al. 1984, very influential. And they drew from public stigma scales across health conditions. So hearkening to this earlier concept I was pointing to. They also pulled from cancer stigma studies. And they came up with these 6 different dimensions. I won't read them all, but one of them includes financial discrimination. They map onto the Jones dimensions quite nicely, and they describe general cancer. Let me go to another self-stigma scale, a commonly used one. This is the lung cancer stigma scale. So they pulled this scale from the Berger HIV stigma scale. So again, there's a kind of a reliance on what's come before. That's good and could potentially be limiting as well. Validated in a US internet sample. And they used this concept of perceived stigma. So that's really anticipated, evaluation discrimination. And then they had these, concepts map out stigma and shame, social isolation, discrimination, and so on. So just a couple of observations about, the scales that at least I'm aware of today, that most cancer stigma scales take from stigma scales from other conditions, either from general health conditions or from mental illness and HIV. And again, I think that's that's both a strength and a weakness, because well, we can get into the whys of that, but it is both a strength and a weakness. A lot of times the scales don't use an explicit orienting framework or theory. Some scales that do are based on frameworks or general sort of overarching frameworks like perceived stigma, etc. One thing that I have noted as well is that almost all scales are developed in US or UK samples. And so really developed in those two countries and then exported, translated, and then validated in other contexts. But as befitting the workshop, is that a sufficient approach to really think about stigma of cancer that occurs in LMIC? So that brings me to the second part of my talk, which is really getting into talking about standardized approaches to measuring stigma across contexts versus a culturally tailored one. And so in the reviews that I've had a chance to participate in for mental illness, there are really two main methods that are used. First of all, as I said before, the measure is developed in the US, UK, Australia, used among Western European folks, and then translated with little or no modification and exported across the country. Occasionally, the measure is developed, number two, is developed across multiple contexts, but then it's seen to reflect universal aspects of stigma. I do want to say, of course, I'm a psychometrician, so I really appreciate this is the standard way because it enhances scale reliability, generalizability, and comparability. And I'm a big advocate for that. We need to do this. However, one inadvertent consequence is that it eliminates stigma's culturally salient aspects. We heard about this from presentations yesterday. India and Kenya, as well as Dr. Johnson has some really nice, vivid examples as well. So this is a review that I did in 2014, where I took a deep dive and took a look at, in stigma measures for mental illness, how many were actually developed in a non-Western setting. And so in this review, we identified 196 articles, and I looked at specifically in culturally diverse groups. So I was really looking to try to find studies that were done in different contexts and cultures. The main findings are that 77% of the studies used translations of Western to US, UK developed measures. Only 2% of studies used a quantitative measure that was developed in a non-Western setting. The rest of the studies use qualitative methods. And so it just left me with this question: how do we address this really, this core gap in terms of understanding how stigma might manifest in different cultural contexts? I also want to say, at least in mental illness, and I'm guessing probably the same is true for cancer, that the interventions to date in mental illness stigma are basically follow the same pattern. So this was a review I was a part of more recent. We identified 25 intervention studies, and here for mental illness stigma, and only 20% of studies considered cultural meanings, values, and practices. So the same gap really exists in stigma interventions for mental illness. So again, I think that cancer stigma was such an exciting point. How can we, in some ways, we have the opportunity to leapfrog, other forms of stigmas that, have maybe, quote unquote, have a longer history or more well developed, but have really historically neglected, some very, very important issues. So again, I just want to note here again, I'm a big advocate for standardization. Reliability, generalizability, comparability, very, very important. But is there also an approach that can illuminate the centrality of cultural variations in stigma? And we know that stigma of cancer varies across LMICs. We've been hearing about this all during this wonderful workshop. And these present notable barriers in services and contexts that have lower levels of cancer awareness. So this is where I want to take the work that I did in 2005, starting in 2005, and really been doing for the past 2 decades. And this is concept of what matters most. And this is a concept that I took working with a really preeminent medical anthropologist, Arthur Kleinman. And his concept is, in a nutshell, it's to engage in what matters most is to certify individuals having full standing within a cultural group. what's key here is that these activities or these capabilities that construct personhood can be empirically identified and operationalized in different cultural contexts. And so this enabled us to advance a new theory of stigma. So in 2007, I wrote a paper with him in social science and medicine. And this is the core sentence. It reads, mental illness stigma acts in cultural salient ways to impair an actor's capacity to take part in the core everyday engagements to certify one as a fully viable or fully moral member of a local community. And let me say that in more plain speech. In order to be part of a local cultural world, you have to engage in a set of core everyday activities that mark you as a full-fledged person in that world. Okay, and these set of activities differ by different settings. They can be highly gendered, as for instance, Dr. Johnson talked about earlier, and I have some examples of my own. So stigma affects everything about a person's experience, but the core of the theory is that where stigma coalesces most powerfully is around these things that determine personhood in every setting. So let me take this to a local example. I should note that this paper, thankfully, had filled up a hole in the literature, and so it's been highly cited since 2007, as you can see. And since 2015, I've taken it to Botswana and utilized this to look at HIV stigma, and I'll apply it to cancer stigma in a second. So in Botswana, what matters most is highly gendered, and this is true in a lot of LMICs. So for Botswana women, what matters most is to bear and raise children, respect her husband, be the foundation of her home. And stigma should coalesce around these capabilities most powerfully, HIV stigma in this case. And so to pick this, with a heuristic, so stigma impacts, everything, the individual, and then the social domains reading it out from the individual. But where it coalesces most powerfully is on what matters most. And what matters most, again, differs by culture, but the theory enables us to identify what it is. So let me just illustrate three main points using Botswana as an example. So what matters most from their words? A woman with HIV says, with women, if you don't have children, you're not a woman. Well, there it is pretty clearly. Then a man says, a proper woman is judged by the community. Her standing is reflected by the way she takes care of her children. So she's bathing them, making sure they have food to go to school. So this is what matters most in this context, according to the respondent. So what matters most shapes stigma, that diagram I just showed you a second ago. So HIV stigma elicits promiscuity, which attacks womanhood and motherhood directly. And so here you can see the quotes. They think that someone living with HIV is very sexually active and promiscuous. I'll jump to the blue. Botswana mostly think that if you have HIV, it means you have unprotected sex in multiple parts. Then a man says, we take it that a woman belongs to the home, so we wonder if she has HIV, there's no woman in her. So again, unfortunately, HIV stigma attacks, again, this core marker of personhood among women. So just bear with me here, because we had this discovery, maybe in the last round of work that we did, that basically, if you can fulfill the dictates of personhood within your culture, then you could actually use that as a shield against forms of HIV stigma. So I'll use this with this example. It's probably most clear. So for mothers with HIV who were able to bear and raise children and then attain this status of respected motherhood, they could actually use this to mitigate HIV stigma. So here's a quote from a woman. I think that a lady who's HIV positive, who's got kids, is much better off than a childless HIV negative woman. And then a man says, the woman who has HIV has been treated better having children because that person has dignity. So hearkening to my good colleague Laura Nyblade's words from yesterday, it's great to have these ideas, but you got to put into numbers. You got to measure quantitatively. So that's what we embarked upon next. So what we did, you can see here, we have this from all the qualitative work that we did. We took the what matters most and actually operationalized then the items. And here you can see the promiscuity quote that I read you, and the corresponding item reads, most Botswana believe that a woman with HIV is promiscuous before marriage. And again, that shapes stigma in this context. So we had two different subscales, and I have exemplar items here. The first is around what matters most shapes stigma. So again, this is the promiscuity item that I just read you. But then the opposite is actually, I believe, even more of a contribution, and that the cultural capabilities of personhood actually protect against stigma. So here for women in Botswana, so most people in Botswana will respect a woman with HIV who raises successful children. And then there are a number of items that are like that. So proof is in the pudding. What we did construct validity, published this as an AIDS in behavior. So this is the Berger stigma scale. Actually, there's obviously a well-known stigma scale, and it's associated with depression, social support, and self-esteem in known ways. And then we looked at the culture protect scale, and it should actually associate in opposite ways as the Berger scale. So this is what happens. What happens actually is that the Berger scale is associated with higher stigma, lower social support, higher stigma, lower self-esteem. The culture protect scale actually has the opposite set of associations. So what happens is that the more that a woman believes that a culture protects against HIV stigma, fulfilling womanhood, so to speak, actually experiences higher social support and higher self-esteem. So to say that again in plain English, the more that person believes that fulfilling the dictates of personhood in their local culture, the more they adhere to this belief, the more positive psychosocial outcomes they had in terms of mitigating HIV stigma. So let's now move this to cancer stigma. And this is anecdotal, but this is talking to colleagues in Botswana. Again, what matters most in motherhood to many women. So an example here is breast cancer stigma, breast cancer and breast cancer. So in this case, you can imagine, right, if motherhood is what matters most, from this clinician's report, she was telling me that basically mastectomy was highly, highly stigmatized because it's a manifestation of motherhood. And so, and that she was really struck by how even super high risk cases basically would really, and it was life-threatening, could be life-threatening, basically would really, would basically, could choose not to have the procedure because this cultural value was so important. And so the theory also enables us to provide a culturally salient intervention. So the message could be that you can still meet key maternal roles even if you've had a preventive mastectomy, right? That would be the core message that hopefully would make this more amenable to women in this culture. So bringing this over to the current supplement that we're doing in Vietnam, and again, thanks to NCI for this support, we're qualitatively interviewing 40 respondents with HIV and who smoke in Vietnam. This is part of a larger R01, PI Donna Shelley, a good colleague of mine at NYU. And we're utilizing this framework for qualitative interviews, and then we're going to develop measures just how I described it to you in Botswana. And so we're only through the first 8 to 10 interviews, so I have some preliminary findings, but just to illustrate. So in Vietnam, what matters most for many Vietnamese folks is living with harmony, with morality. So the thinking is, so one is to think and live for the community and gain respect in the community. So what's very interesting so far is that there are actually very low stigma quantitative scores that we found so far in this sample towards general cancer and lung cancer. And the reason is actually, I believe it's what matters most related. And this is actually a quote that explains it. A respondent actually said, there's no cancer stigma because people still live harmoniously with others and with an open mind. So in this cultural setting, it's interesting that because the cancer really affects the individual and that individual's family and doesn't disrupt larger society, there appears to be less stigma associated with it. But I have a hypothesis. I think that's just the surface though. The key thematic impacts of stigma that we've seen so far are impacts on employment, financial burden and treatment, burden in family time and caring for the patient. And so my hypothesis is that basically stigma of cancer is going to be associated with, of course, when the person is not able to fulfill what matters, right? So when there's a failure to meet one's roles in the community. So for men, it's to earn income and accumulate prestige. And so when cancer interferes with that, then all the stigma will kick in. And so here you can see, again, a roadmap to protect against cancer stigma. This is actually a respondent quote, and they're giving us the roadmap again. If a person with early cancer early cancer minimizes impacts through treatment, they can work normally and still be respected. So again, it's fulfilling the dictates of what matters most, personhood in that context, and then fend off stigma. And in this case, probably in many contexts, it's early detection. And just wrapping up. So I just want to end on this slide. I think I've raised a lot of questions, and it was intentional. I don't have all the answers, but I just, just as an observer and hopefully future participant, I think it's just worth discussing. The cancer stigma scales have really connected quite nicely to that of general health conditions. It's a very nice interplay. There are strengths and weaknesses to that, though, and to that approach. There are general cancer stigma scales. There are subtypes of cancer stigma scales. There are reasons, good arguments to have both of those as well. But where should the emphasis be moving forward? One of the things that I've seen, I think that is a relative weakness, is because it's the borrowing from the other fields. There's less work that is around actually the lived experience of cancer stigma, although there are some notable exceptions. So for instance, yesterday's present lung cancer inventory, which did some really superb exploratory work beforehand. That's the kind of work that I really, that the field, I believe, really needs to tap into. And then other things around advances in stigma concepts. The social psychological theories are great, very, very influential, but there have been a lot of advances lately, especially around structural policy forms of stigma. There's a lot of thinking around that. And again, why can't cancer stigma scales just leapfrog, other conditions and really just go straight to incorporating these new concepts? Intersectionality, another big and hot area, and there's a lot of efforts now around intersectionality and HIV. And then lastly, I'll just come back to the original question that I posed. How can new cancer stigma scales best capture dimensions of lived experience of cancer in LMIC? And so we want to maintain the rigor of measurement, but we also want to capture commonalities of cancer experience. I think that's a very important point. Dr. Johnson raised that. But there are also some very, very important cultural dynamics that are typically at play in LMIC. And so we need rigorous theory and empirical work to illustrate the lived experience of cancer in different LMIC, right? We're past this point where we just develop scales in the US, UK, and then export it and just expect it that everybody, experiences cancer stigma in the same way. It's very narrow-sighted, narrow-minded, very narrow-sighted, and it's something that we have the opportunity to address as this subfield emerges. I'm very excited to participate in. Thank you, and happy to take any questions.
Thank you so much, Larry. That was wonderful. It really was. And there's a lot of conversation in the chat, not surprisingly. I think a lot of the ideas you brought out, and I know for me, this idea of stigma coalescing around what matters most to the individual or culture is a really, I think, valuable way to kind of move forward. And so thank you for sharing that with us. It looks like there is a question in the chat, which is, can we develop scales with core compulsory elements and peripheral elements that can be adapted to cultural context?
Yes, I really like that. So I think that's the way to go. I think that we can develop, I think with rich, but this is the way that I would do it. All right. This is a fantasy sort of world, but if we were to do lived experience of cancer stigma in different contexts, then we could actually triangulate and see what is shared, right? What's common between those contexts if we did it in a really, really rigorous way, as opposed to just assuming, oh, we do it in one context and then apply to everywhere else, right? We could identify what's common and then we can identify what's distinct. And that would be, I think, the gold standard way of doing it. You could imagine, right? You'd have this core, like you can call a backbone of cancer stigma, so to speak. And then you could have different, for different settings, there could be cultural sort of, additions or appendices.
That's great. Does anybody else have any questions? I feel like I'm very inspired. Of course. But yeah, Bill, oh, so many hands. Great. Well, let's take a few minutes and go through them.
Actually, let me give the floor. We have limited time, so let me give it to Benda and Bill, and I can always reach out to Larry privately.
Okay.
Go ahead.
Go ahead, Bill. You're next in our line.
Thank you, Vidya. And I had a very quick question, and I'm giving away something I'm going to probably mention at the very end when I have my final remarks. But I wondered about the extent to which we know anything about implicit measures of stigma, because a lot of stigma is experienced implicitly, and also prejudice and discrimination are also the kind of thing that's studied implicitly as well as explicitly in the psychological literature. And I haven't seen too much mention of implicit measures, but of course they can capture something very different beyond what these more explicit measures might capture. So any thoughts about that?
I'm so glad you raised that, Bill. Yeah, there's a huge effort, obviously, and within mental illness stigma, for instance, there are implicit measures of mental illness stigma, and they tap into different things, and explicit measures of mental illness stigma do. I have to confess that I haven't stayed on the literature 100%, but I also, I just so you're all aware, I think there's some controversy these days around, what exactly, right, implicit stigma assesses, and how well does it correspond to the stigma that we're interested in examining. So I think there's a hard look right now, at this very issue. But I think it's still a valuable area of inquiry for sure, and it would be, combining explicit and implicit measures is ought to be a strength.
Great, thanks.
And then Benda, why don't you have the final question?
Thank you. Thank you so much for that presentation, Dr. Young. So listening to you, there is a clear disparity between how much research has been done in developed countries versus LMICs on stigma. Tools have been developed also that address stigma in developed countries as well. How can we address this disparity while not losing track of what gains have been done in developed countries so that we can fast track development in low and middle income countries? Could you speak into that?
Yes. Benda, did you presented on Kenya yesterday, is that right?
Yes, I did yesterday.
I just want to say, you did on 1,000 USD. What incredible work you did. I just want to say that publicly. So, well, listen, I think that's exactly, the kind of work that you're doing is exactly what we see. We need to see that it's not that there are some very strong commonalities. You presented on death sentence, right? On The Walking Dead. Like, there's very things that cut across cultures, but then there are things that are just very particular. Witchcraft. I remember from your presentation, right? That's not common to other settings, but it's very powerful. It was in the top 5, and so. And it plays a role in everyday life in a lot of African settings. So these are the things that we need to bring to the table and say that they matter, and that people seek or don't seek cancer treatment based on stigma from these different sources. I think that's the really valuable contribution. So please continue.
Well, thank you so much. I know, again, you'll read it in the chat, but this was fantastic and everyone really, really appreciated it. And thank you for making this time and being here.
Of course. I just want to note as well, I'm in Korea 13 hours ahead, so that's why I won't be participating in the rest of the workshop. Otherwise, I look forward to, participating in the future.
Perfect. Thank you so much for being here and good luck with everything to come in the next couple of days. Yeah, exactly.
Thank you so much. Thank you, everybody.
Yep. And now I'll turn it over to my colleague, Dr. Robin Vanderpool.
Good afternoon, everyone. We just crossed the noon hour here on the East Coast of the US. I did want to just take one moment and say we want to think about our colleagues who might be in Florida today and up the East Coast. As you all know, we have a major hurricane in the US yesterday and today and into the weekend. So just wanted to send my thoughts out to our East Coast colleagues. As we now transition to our next and last panel of the workshop, we are honing in on interventions for cancer stigma. We've heard so much about the impact on patients and families and society. We've heard so much about measurement of stigma, and now we want to turn our attention to exemplars of interventions to address cancer stigma. And we have 4 excellent speakers this afternoon. I encourage you to read their biographies that are put. Can you all hear me now?
Yes, we can hear you.
Okay, for some reason I was externally muted.
Yeah.
I'm sorry. So we have 4 wonderful speakers this afternoon. I would encourage you to read their full bio sketches on our conference website, but we will be traversing the entire globe from Nigeria to China, to Kenya, and to rural communities in the United States, including Kentucky. So with that, I'll ask the speakers of this first session, or I'm sorry, our first speaker, to turn on their camera. Chigozie, please. All right. Please let me introduce Chigozie Nkwanta. Did I do okay?
Yes, you did.
Okay, great. Chigozie is a postdoctoral fellow in the Behavioral Science Training Program at New York University, and we are so pleased to have you here to speak about community-based interventions to reduce stigma and improve knowledge of HPV and cervical cancer in Nigeria. All right, the floor is yours.
Thank you, Dr. Ravi, for the introduction. I will share my screen. Can you see my screen?
Not yet.
Okay.
Okay, it's starting to work.
Something is not letting me adjust it.
We can run the slides for you.
I was going to ask, would you like us to run your slides for you?
Okay. Okay.
Okay.
Thank you for the introduction. So some of my work, we talk about Dr. Lawrence, who is my mentor. Some of the things he presented are kind of related to my work. So my study is an intervention to reduce stigma and improve knowledge of HPV and cervical cancer in Nigeria. So I'll start by presenting, providing a little background about HPV, talk about the conceptual framework I used for the study, then the methodology, the findings, and finally the conclusion. So just a quick little background about HPV and cervical cancer. We know like cervical cancer is highly stigmatized because it's caused by a sexually transmitted infection. And HPV is one of the commonest oncogenic viruses, which is associated with 6 different cancers, which is cervical, oral, penile, vaginal, vulva, and anal cancer. And the prevalence varies by geographical regions. It's a very preventable virus, and the cancers are easily preventable by HPV vaccine, regular screening, healthy lifestyle, and also safe sex. So, but the infection remains a major issue in sub-Saharan Africa, especially in countries like Nigeria. So the prevalence, I'll provide the prevalence of HPV in Nigeria. It is estimated that 32% of people living with women in Nigeria have a HPV virus, 42% in the northern part of Nigeria and 26% in the southern part of Nigeria. And majority of these women are less than 30 years. Cervical cancer, which is the commonest cancer caused by this virus, it's the second most common female cancer in Nigeria, and also the second leading cause of death in Nigeria. Because most of the patients present they present at advanced stage. So like 70% of them come in at a very late stage. So I'll give like a little bit background about Nigeria. It's almost like 2 countries in one. So you just have an idea of my study and my intervention. So my study was conducted in Anambra, which is one of the states in the southern part of Nigeria. So the southern part is the Christian educated section, the northern part is the Islamic less educated part of the country. So we have it's a very diverse, we have so many cultures and so many languages. So a little bit diverse in the way we do things and the way we view things. But the state where I did my studies, the 3rd most densely populated state in Nigeria, and it's highly urbanized state too, with very religious and also ethnically homogeneous states. So the reason for this major thing that motivated this study is there is currently low uptake of HPV and cervical cancer screening in Nigeria. And also the awareness of both diseases are low in Nigeria. Then being a patriarchal country, there is lack of decision-making ability for women. The women don't have the final say in terms of whether they can access healthcare or they can take the vaccine or their children can take the vaccine. So men are regarded as the people in charge to make the final decisions. Then also the cultural practice, HPV being a sexually transmitted infection and causing cervical cancer. There is cultural expectation that women are expected to be modest. You're not expected to be sexually active. So for you to get sexually transmitted infection, it has another layer of stigma on it. Then also cost of taking these services. We don't have national program where HPV vaccine are being paid by any insurance or paid by or subsidized by the government. So the cost is paid out of pocket by families, and most women in Nigeria are dependent. The financially, the men are meant to get the money in the family, and the women are meant to stay in the house and take care of the family and be the homemakers. Then also there is huge lack of male involvement in reproductive health in Nigeria. It seems that anything that has to do with reproductive health or has to do with women health is the mother's responsibility, even though she doesn't have the final say as to what should be done. But the men hopefully most times don't get involved in any reproductive health issues. So the objective of this study, we evaluated the effectiveness of the educational intervention and knowledge of HPV and cervical cancer, the effectiveness of intervention on their intention to take the vaccine or go for the screening, and also how the effect of the intervention on perceived stigma regarding HPV and cervical cancer. So the conceptual framework we use two conceptual frameworks. We use the theory of gender and power, which talks about how the depth of sexual equality between genders and the power imbalance. So how three different structures, the division of labor, how lack of finances and the marginalization of women affects the ability to make decisions, or their exposes their risks to poor health. Then also sexual division of power, which is how those factors affect their ability to make decisions, and the cultural aspect of it, which is what is expected of the woman and what the woman thinks is she's supposed to do in the society. Then the second conceptual framework we used the process adoption process model, which talk how an individual goes from not being aware or getting information about a HPV or cervical cancer or any particular health problem to health information to either decided to go ahead and take the health services or not to take it. So it's a 5-stage, it's a 7-stage model, but we adapted the first 5-stage. So this is a quasi-experimental study, was a pre and immediate post-test. So this was part of my dissertation. So it was an immediate post-test intervention. The criteria we used to make sure that the participants, because Nigeria, officially it's an English-speaking country colonized by British, but we have other languages. So the major thing we did was to make sure that the participants should be able to understand, read, and write in English, which is common, and also between the age of 18 and 65 years. Then the sites that we used for the intervention were churches. We used 2 churches, 5 organizations, which included workplaces. We used industries. We used small offices. They also used family compounds. So family compounds are like homes. This study was done during the festive period, which is December period through January, which is usually a time when most people go back to their ancestral homes and stay. So when you get to each family home, you're going to see, sometimes you see like 20, 30 people in one family home. We also used educational institution and a hospital. So the interventions we used was a face-to-face presentation and a pamphlet. So we chose pamphlet as part of the intervention because before this study, we did a primary study where we asked the participants what intervention, how would they want to get health information? And more than 50% of them said they want something to read, something they can keep in their refrigerator, so to remind them to go for health services or to go get the screening or to do whatever we're asking them. So that was why we included pamphlets as part of the intervention. And this study involved men and women. We included men because we wanted to get them involved. Most of the studies that I saw during my dissertation were all focused on women, but these women have limitations in terms of being able to make decisions and being able to afford the cost of the vaccines or the screening. So, and also the stigma that comes with all the sexually transmitted infection, also cervical cancer. Or it's not only women that treat them; it's both men and women. So we have to get the men involved for us to be able to reduce stigma. So the resources we used to create the intervention, we got it from the educational resource from the CDC website and also Foundation of Women Cancer website. So we had like pictorial, so the intervention, both the face-to-face presentation and pamphlet had the same thing. The only difference is that people with face-to-face presentation had like more explanation and all that, but the people who received the pamphlet had the option to ask questions. So it's not just reading the pamphlets. When they are reading, we are present. So if they need like questions or like anything they don't understand or more questions, I was there to also answer the questions. So we had like pictorial information about HPV. We gave them provided statistical facts about HPV in Nigeria. And also list of like some common misconceptions about the virus and the cancer. Then also list of hospitals or pharmacies where they can get the vaccine or around the study area where they can get the vaccines or where they can go for the screening. So the vaccine is readily available, and also the screening is also, the pap smear is more expensive, but we have VIA, visual inspection of acetic acid, which was more common in like all the primary healthcare centers, and they were very affordable. So we gave them a list of both in case they want to take any of them. So the intervention, so the presentation group, we had 2 groups. The presentation groups, we had 163 people that participated. 75% of them were men, 88% of them were women. Each participant, we gave them the option. We didn't select participants, we didn't assign participants to groups. Participants chose the group they want. So the ones that wanted to read pamphlet wanted the pamphlet. The ones that wanted to listen to presentation wanted to listen to presentation. So we was more focused on like getting the word out there and making sure that we reduce the cancer incident in Nigeria. So we make sure that the participants chose what will be effective for them. Then the pamphlet group, we had 103 participants, 40 of them were men, 60% of them were women. So the pre and post test, we had 44 questions for men and 47 for women. So we had 3 extra questions for women, which was focused on their ability to make decisions, if they will be able to take the services on their own, if they can afford it on their own, if they can decide to go for the services without their husband's consent or maybe some another person's consent. So these were 3 extra questions we added for women. Then 36% of these questions for both groups were on cancer, HPV and cervical cancer. That's their knowledge, their intention, their awareness about to take them. The willingness to pay for it was also things we explored. Then we had just 6 questions for stigma, which we developed from the SARI stigma scale. It's a leprosy scale, and also the CDC stigma questions that we added. So the analysis we used mean, frequency and percentage, and we grouped the questions based on the 13 questions on knowledge. We scored them based on low, medium, and high. We used logistic regression for the other analysis. So when we did the initial analysis, we did between group analysis. We didn't really see any difference. We found out that maybe because the participants self-selected the group they wanted, but there was no difference in terms of people who listened to the face-to-face presentation and people who read the pamphlets. So what we did for the groups were to do within group analysis to see the difference, like if there's a change in the result from within each group. But for the genders, for men and women, we found a difference in terms of differences in knowledge and intention of their and stigma. So for men, for genders, we did between group analysis, and for groups, we did within group analysis. So that's what I'm going to present. So we've practically found they were mostly almost the same thing, except for the incomes. Most men had more money than the women, which is expected because they have more opportunity in Nigeria than men have more opportunity than women. So the first result we have is the knowledge of HPV and HPV vaccine, and we noticed this is for the groups that there was a huge difference. Pre-intervention, they noticed that most of them don't know anything. Majority of them haven't heard of HPV. They don't know anything about it, but we noticed that they've heard about cervical cancer, which I think it's another thing we have to focus on, because when you talk about stigma, you think of people see cervical cancer as cancer, but when they are aware that this is caused by sexually transmitted virus, it's a different thing. So we pre-intervention, we noticed that majority of them were aware of cervical cancer, but which post-intervention that increased tremendously. Then also for differences by gender, we also noticed pre-intervention for HPV. Also, both groups, they didn't know about HPV, both men and women. But for cervical cancer pre-intervention, we noticed that most women were aware of cervical cancer more than men, and that increased more also during post-intervention. Then their intention to take the vaccine or to encourage their family to take the family member to take the vaccine. So by groups, you notice a huge difference. A majority of them fewer were willing to take or pay for it or encourage their family member pre-intervention. Post-intervention, that increased tremendously in both groups, both pamphlet group and presentation group. Then same thing for gender too. We noticed that pre-intervention, most women, just for HPV vaccine, most women were willing to plan to take the vaccine pre-intervention, even though they didn't know about it that much, but most women were open to taking the vaccine more than men. But post-intervention, we didn't notice any difference. Both men also and the women were also open to taking it, but we see an increase in their intention to take it. But the willingness to encourage someone, we found out that more women were more willing to encourage men, were more willing to encourage their family member or to take the vaccine versus men post-intervention. But pre-intervention, we didn't notice any difference.
Chigozie, I'm so sorry. We are running close to our time. If you could start to wrap up, please.
Okay, so I will go to like the stigma questions. So for the stigma questions, we asked them 6 questions, which are like if they think people with cervical cancer sleep with a lot of people, or who HPV sleep with a lot of people. So because they don't know about HPV, it's a sexually transmitted infection, and they weren't aware of it. So pre-intervention, we noticed the majority of participants were within, they weren't sure whether, they were not sure. We had like no, yes, or not sure. So they were really not sure, but post-intervention after the LANT is a sexually transmitted infection. We saw a huge reduction from not thinking that HPV, people who sleep with who have HPV, a lot of people. We saw a huge reduction, and most of them moved from no to not sure. So to not sure. So they didn't move to yes, but it was like they moved from saying no, they don't sleep with a lot of people, to like not being sure whether they to stigmatize them or not. Which also, another thing we also found out that we asked them was if they think it's risky to tell someone they have cancer. So pre-intervention also, fewer people said yes, it's risky. Post-intervention, that increased in both groups. We also found the same thing too also for men and women too. Pre-intervention, they felt it wasn't risky to tell somebody, but post-intervention, there was a huge difference. Like they felt it's very risky since they were aware that it's a sexually transmitted infection. So conclusion, this is just a low cost culturally tailored intervention, which I think since the cancer is, especially cervical cancer, which is preventable, is highly common in sub-Saharan Africa and low-income countries. That any intervention, whether face-to-face or like targeted health education, will be effective in increasing their knowledge and also reducing the stigma, and as well as increasing their intent to take the vaccines. Thank you.
Thank you so much. And there have been some questions already in the chat, and then we'll of course have questions at the end of this panel. So we'll move on in the interest of time to our next presenter, Dr. Tom Fitzpatrick. Tom, are you with us?
I am.
All right. So thank you, Tom, for joining us. Tom is an infectious disease fellow at Washington University, and he's going to be speaking about a crowdsourced intervention to reduce viral hepatitis stigma among men who have sex with men in China. The floor is yours, Tom.
Excellent. I will bring my slides up, attempting to, let's see. Not seeing. Let's see if I can do it like this. Excellent. Here's my desktop. Can you all see this?
Yes.
Excellent. Wonderful. Let me just go into presenter mode. Awesome.
Okay, you're ready to go.
All right, great being here. My name is Tom Fitzpatrick. I'm here at the University of Washington, and I am super excited by all the conversations that we've been having today. I've learned a ton, and I love this kind of multidisciplinary kind of pan-disease approach that we have with this conversation about stigma. And I'd just like to share with everyone how some of the work that we've been doing on using crowdsourcing as a model to decrease hepatitis B stigma among men who have sex with men in China. Let's see, there we go, moving forward. Because we're all talking about so many different diseases, just a little bit of background about viral hepatitis. So there's hundreds of millions of people across the world who are living with chronic hepatitis B and C. And together, chronic viral hepatitis is responsible for more than 1 million deaths each year, primarily through liver cancer or through cirrhosis. As we can see here, most of the burden of disease is concentrated in low and middle income countries internationally, and a lot of that is concentrated in China, where me and our UNC Project China team do a lot of our work. As you can see here, out of the 1.1 million deaths that are associated with chronic viral hepatitis, almost half of those, 400,000 of those deaths from liver cancer or cirrhosis happen in China every year. And a full third of people living with chronic hep B live in China. And one of the biggest issues that we've encountered in trying to improve the hepatitis care cascade in China is that so many people living with hep B and hep C are just unaware of their status. They just haven't been tested, and so they can't be connected with appropriate treatments. So what are we going to do about this as a global problem? Well, in 2016, the WHO has drafted this roadmap for the elimination of viral hepatitis by 2030, an ambitious goal. And in order to accomplish that, we'll need a 90% reduction in incidence of both hep B and hep C, and a 65% reduction in mortality between 2015 and 2030. We kind of know how to get there in terms of the big picture. We know what works: connecting people with hepatitis B vaccination, particularly when they're infants, improving blood safety, and helping people who inject drugs have access to clean injection equipment. And then, of course, increasing access to hepatitis B and C testing so that we can have increased access to treatment. All of these things are important, both at the global level and also at the national level. But what's getting in the way? I mean, this could be a whole symposium in and of itself. There are so many interrelated barriers, from access to knowledge to the fact that it's an asymptomatic infection. But one of the key barriers across many settings is stigma. And this is true internationally as well as in China. Particularly hepatitis B stigma in China has been identified as a significant barrier to testing, treatment, and vaccination. And hepatitis B stigma in China comes in multiple manifestations, and we've kind of talked about the complexities of stigma over the last 2 days. In China in particular, hepatitis B stigma is associated with social isolation, denial of employment, denial of educational opportunities, and really does have a lot of salience in that particular context. Despite it being so important, there are really not too many published interventions to reduce hepatitis B stigma in China or elsewhere. So we at UNC Project China have used crowdsourcing as a solution to some problems in the past, and we were thinking it might help with hepatitis B stigma. Now, what is crowdsourcing? So we've probably all heard the term before. It's been around for about 20 years now. And in general, it's a pretty broad concept, but the idea is that you take a problem and you present it to the public. You then collect ideas about how to address that problem from the public. You refine those solutions, and then you share it back. The idea about this is it brings together experts and non-experts to share their collective wisdom, and it actively engages effective communities in producing solutions to the problems that they're living with. I think one of the great strengths of crowdsourcing conceptually goes back to what Dr. Yang was talking about not too long ago, this whole idea that there in each cultural context, there are different ideas about what constitutes personhood, and as a consequence of that, where stigma manifests. And the idea behind crowdsourcing is you're tapping into that collective wisdom about what stigma is, what motivates it, and how we can use certain strengths of a culture in order to address stigma. Now, crowdsourcing can come in a whole bunch of different forms and flavors, everything from hackathons to challenge contests. One of the things that we're really comfortable doing in China is these challenge contests. So we solicit slogans or images or strategies from the public, and then we evaluate them, and then we disseminate them back out to the public. And that's exactly what we did with this crowdsourced intervention to reduce hepatitis B stigma. So back in 2017, 2018, we got a bunch of organizations in China that deal with viral hepatitis together. We use their cultural connections, social media connections to solicit images and videos, both promoting hepatitis B and C testing and addressing hepatitis B related stigma. Over the course of 3 months, we collected more than 150 images and videos. And then through some expert and community judges, we scored those submissions and then gave people feedback about how they might be improved and asked them to resubmit. Ultimately, we selected finalists based on those final scores that they got after resubmission. And then 4 finalists were selected as the winners of this crowdsourcing contest. I have to say, I was super impressed with these 150 some odd images and videos. This was the first time that we had run a hepatitis related crowdsourcing contest, and the creativity, the ingenuity, the design skills just really blew me away. These are some examples of posters that people presented to encourage testing and also deal with the complexities of stigma. Some people really went all out, and they produced whole web comics that described their personal experience as someone living with hepatitis B, the stigma they encountered, and how they had overcome that stigma in their life and worked with their loved ones to overcome it. This is a selection of one of those web comics. So this all looks great, but the question is, does it work? Does it help with stigma? Does it help with testing? And so we aim to evaluate that. The question is how best to evaluate that. Well, we had a lot of experience with a research group in China working with men who have sex with men. And they seemed like a perfect group to kind of see if this was a good strategy, because not only do we have that experience and those connections with men who have sex with men in China, but they're also at increased risk of hepatitis B infection, and they have low rates of testing. And so what we ended up doing is a nationwide online RCT. We recruited 556 men who have sex with men in China through social media. They hadn't been vaccinated to Hep B. They hadn't been tested before for viral hepatitis. And then we asked them to complete an initial survey. We then randomized them to either see these crowdsourced materials over the course of a week through social media or see nothing, no controls. And then we came back to them 4 weeks later and had them repeat a follow-up survey. We also asked them whether or not they had gotten tested. On both that initial and that follow-up survey, we had asked them to answer questions to assess a stigma score. We use the Toronto Chinese Hepatitis B Stigma Scale. It has these 4 domains here. It's previously validated. It has 20 items in which people either agree or disagree with certain phrases or sentences. And based on that, you end up getting a score from 20 to 100, 20 being almost no stigma, 100 being scads of stigma. And then we assess this again at that initial and then that follow-up survey to see whether or not exposure to this intervention, this crowdsourced intervention, did anything. And so in our as exposed analysis, we grouped these people into full exposure, partial exposure, no exposure, based on how many of those materials they had seen during that 4-week period. Because we knew that some people, even with randomization, through social media, would choose not to view those materials. And because social media is a medium in which people share things, even if they were randomized not to receive those materials, some people might have shared materials with them. So we conducted this as exposed analysis to see what happened to stigma scores. And what we found is that stigma scores among people who had seen the materials decreased by about 4 points. And that was statistically significant compared to men who had no exposure to the intervention, who had not seen those materials. We saw that this reduction in stigma scores held true across all 4 of those domains. 3 of the domains had a statistically significant reduction in stigma. You'll see that physical contact did not, but it did have it followed the same trend as the other domains. So what does this mean overall? Well, I think it means that there's potential here. A crowdsourced intervention seemed to reduce stigma scores among men who have sex with men in China. Something I wasn't able, because of time, to go into is we then, in the subsequent years, in 2019 and 2020, went on to use this exact same model in a Chinese primary care setting. And we exposed people who were coming in to see their PCP to these same interventions versus no materials, and saw a similar reduction in stigma scores. So I think we believe we can say that there's a potential here for crowdsourced interventions to reduce hepatitis B stigma, both among men who have sex with men, and then probably among the general population in China. But then lots of questions remain. Does this relatively modest reduction in stigma score actually result in durable change over time? Does it have a meaningful impact on health outcomes? That remains unknown. We need more research to look at it. But I still think it's exciting, because one of the great things about crowdsourcing is that it's not specific to a disease. It's not specific to a context. It taps into that wisdom no matter where you are. And so it might be something that can help with, say, cancer stigma. So I just want to say thank you to everyone for this time, and particularly thank you to all the CBO partners and the contest participants that made this intervention possible.
Terrific. Thank you so much, Tom. Quite a few compliments coming in through the chat feature that I hope you can look at as we move on to the next presenter. Really appreciate the creativity of the participants in that study. All right, we're going to move on now to Dr. Megan Hutchko. Megan, are you with us?
Yes, here I am.
All right, thank you, Megan. So thank you for joining us this afternoon. Among many titles, Megan is an associate professor of global health and obstetrics and gynecology at Duke University. And here she'll be presenting some of her HPV-related stigma research among communities affected by HIV in Kenya. The floor is now yours, Dr. Hutchko.
Great, thank you. Let me share my screen. Okay. Now, do you see the slideshow? Great. Okay, I am sorry I had to miss yesterday. I teach on Wednesdays and wasn't able to get out of it, but I've already enjoyed learning from everyone this morning, and I feel like a lot of what was said in Dr. Johnson's talk and Dr. Yang's talk is really relevant to what we're working on in Western Kenya. So I'm going to talk about Elamisha, which is a name for our multi-level intervention to address HPV-related stigma among communities affected by HIV. I have no conflicts. And as background, as we've all heard, in addition to the logistical and cost barriers, there are individual and provider level factors, which certainly include stigma, that contribute to women's decision to screen for cervical cancer and then to complete their journey through the whole cascade from screening to appropriate follow-up. And as we've seen demonstrated really clearly this morning, studies have shown that cancer-related stigma and specifically cervical cancer-related stigma can be common in LMICs. It's unclear. I think we've all been talking about the quantitative gap. How does this actually relate to prevention behaviors? And in addition to the cancer and the cervical cancer specific stigma, testing with human papillomavirus or HPV can bring about additional stigma, given that HPV shares risk factors with HIV, which can be a stigmatized disease. It's sexually transmitted. And there have been studies from Europe and the US which show that a diagnosis of HPV can be traumatizing and carry stigma for many women. So as this is becoming more increasingly available in low and middle income countries, it's important to think about how those three stigmas, HIV, HPV, and cervical cancer intersect and interact, and how programs can think about HPV-related messaging and services to mitigate the impact of HPV-related stigma. We've been working in Western Kenya in Kisumu and Kisumu East counties for about the last 15 years. These are areas of Kenya which have been targeted by PEPFAR and ASCOF for services because of the high rates of HIV. There are a wide range of estimates, but consistently it's felt to be less than 1 in 4 or 1 in 3 women have been adequately screened for cervical cancer. And Kenya is strengthened by a national cancer control program, which has set out now 3 sets of guidelines on cervical cancer control. And the latest ones do recommend HPV-based screening. And as screening is scaling up with HPV, it's important to think about how HPV-related stigma may also impact uptake of vaccines. We're not going to talk about it here, but we're doing some work looking at parent and caregiver decision-making about adolescents for vaccine girls. And I think messaging and understanding of HPV and HPV risk will be really important as it carries over to decision-making about HPV vaccines. So we've been working to implement cervical cancer screening, first with visual inspection and now with HPV-based screening for the last 15 years. And the impetus for some of the stigma-related work came from qualitative interviews we did with women who got lost to follow up across the screening cascade. And they suggested that stigma could act as a barrier across the cascade. And this stigma was manifesting as social isolation and shame around the diagnosis of HPV. And all of that was sort of overlaying all of that was this fear of a diagnosis. And I think, as Dr. Johnson stated so well, if there's no treatment for this, fear of being labeled with something or having sort of a diagnosis that carries a label but wouldn't necessarily be treatable. So we sought with a 2-year R21 from the Fogarty Stigma Network to develop a framework to help describe HPV and cervical cancer related stigma in this context. And look at how it might interrelate with HIV-related stigma, and look at some of the both drivers of stigma and the positive facilitators that would decrease stigma or mitigate the impact of stigma. So we undertook in-depth interviews, we developed this framework, and then the second part of that R21 was to develop a measurement tool. So we'd be able to quantitatively assess both stigma levels and predictors of stigma levels, and then their impact on screening behavior. So I think we're at sort of that tension. We've really experienced that tension of how to translate what we find in our observations and our qualitative work into these quantitative surveys. So we used the framework, we used existing literature, we looked at existing stigma scales for cancer and HIV, and adapted some of the questions and developed some questions de novo. And we went through a pretty rigorous process with cognitive interviews. And then we did an internal validity exercise using exploratory factor analysis with about 1,000 women. And then we tested a more finalized version of the scale among almost 500 women to evaluate construct validity. And here are just some examples of the items that we use. These are items that stayed in the final scale. So some of them are related to or similar to what we would see in the HACCP or the Hershey. So if I had HPV, people would avoid me. Or for example, if I had cervical cancer, I would not be allowed to participate fully in the church or mosque. Through our exploratory and confirmatory factor analysis, we pared down the initial set of items by almost 50%. And while this is preliminary, we're still finalizing the analysis. We saw that stigma scores for HPV and cervical cancer were similar to scores for HIV. They were slightly less, but we haven't which in the region we work in had significantly higher stigma scores than women who responded in English. Items marking shame or blame scored the highest. And then we're doing this ongoing analysis to correlate with screening behaviors. All right, so based on those results, we sought funding and were able to get a small R01 from the Same Fogarty Stigma Network to develop and test an intervention, which we feel like addresses some of the factors related to stigma that we've seen, and we'll be able to use the stigma tool to measure the impact of the intervention on levels of stigma and screening behavior. So we have identified 8 overall components of the multi-level intervention, 2 of which, offering HPV via self-collection and offering results via text messages, are so intrinsic to the feasibility of the screening campaign, and women have so strongly preferred these methods of both screening and results notification. We do feel like they're stigma responsive, but we would offer them in both control and intervention communities. So the 6 unique components of our intervention include an educational video and culturally tailored brochures to augment the educational piece. On the right side of the screen, you see a screenshot from the video. This is a woman who is describing her own experience going through the screening and treatment process. And the goal of the video is to provide the psychosocial support and address the fear and emotional aspect of screening, and it's to augment these culturally tailored brochures and then the refined standardized scripts for the community health volunteers who are providing the information. So we'll address communication norms by reviewing all of our content for clarity, language, and positive motivation. So focus on actionable activities and the positive steps of going to get the diagnosis and what we've learned about the empowering aspects of getting treatment. And then we've learned a lot about workforce challenges and thought about workforce optimization. A lot of women who've gone through the screening process have expressed interest in being peer navigators. So we're developing a peer navigation system for women who delay in screening or in accessing treatment. And then something that arose somewhat consistently through our qualitative work were some concerns with both the messaging and the trustworthiness of community health volunteers. So we found some interesting professionalism training from the HIV literature in Brazil, and we're working to adapt that to train the CHVs in professionalism and adjust that trust relationship. So again, we just got the NOA for this a couple months ago. So we're very much in the preliminary phases of working with key stakeholders to adapt all of these planned components of the intervention. Once they're adapted, we're going to do a cluster randomized trial in 12 facilities to look at differences in screening uptake among women and then successful access to treatment among women who screen positive for HPV. And because this is being done in Western Kenya, where there are high numbers of women who are living with HIV, we wanted to look to see about any potential impact on engagement with HIV care. And then we'll use the newly validated tool to measure just the stigma outcomes and how stigma mediates some of these behaviors. And finally, because I feel like we can't answer everything with the quantitative scale, we're going to do a convergent mixed methods design to use more qualitative data from key stakeholders to look at the individual and the facility level factors that may moderate the effects of the intervention. So we're hoping, so we do have some progress to date. The video was developed by a fellow through a D43. So we have a pilot that we were able to do some workflow surveys and observations to look at how it was actually implemented, what were some of the barriers to getting women to see the video. And then we carried out some focus group discussions with women to talk about their experience with the video so that we could start modifying that right away. So we're just in the process actually of looking through the script and looking through the focus group discussions to see what we would change for the launch of the study. So I don't have a conclusion slide, just next steps, because we are just getting this started. So we're finalizing the components of the intervention this fall, and trying to get pretty structured feedback through with key stakeholders at the facility provider level, but of course at the target women level. And then working to edit the video, and then we'll be hiring and we'll identify and train the staff and hopefully launch this RCT next spring. So I'm happy to take any questions now, or we can talk more at the end of the session.
All right. Thank you so much, Megan, and good luck with the remaining parts of your study. Very exciting. And we will move on to our next presenter and take all the questions at the end. But please, folks, the chat has been active, so let's keep it going. Our final speaker for this particular panel is Dr. Jamie Stutz, who is a professor of medical oncology at the University of Colorado. Well, I started to say the Cancer Center, but the University of Colorado, and is also the co-leader of the Cancer Prevention and Control Program and the co-director of the Population Health Shared Resource Facility at the University of Colorado Cancer Center. Jamie and I are longtime colleagues from the University of Kentucky, and I'm really thrilled that he can be here today to present on his work in addressing lung cancer stigma. The floor is yours, Jamie.
Thank you, Dr. Vanderpool. This has just been an amazing past couple of days, and I will admit to feeling a little bit of pressure being the last speaker before Bill gets to share his comments. But really excited to continue the discussion about the work that's being done in lung cancer stigma, more specifically in the United States context. Recognizing the limitations of that context and its ability to generalize. But I want to take a second to highlight a couple of these pictures. One is a picture of some folks associated with the White Ribbon Project, which is
Jamie, I'm so sorry. We're seeing like your two slides together, like your notes and your.
Oh. Better?
Yes, that's better.
Sorry about that. I thought I had it all worked out.
Oh, good.
Okay, so let me share the picture up on top is the White Ribbon Project, which is a grassroots organization designed to provide more support and compassion for individuals diagnosed with lung cancer. And then the lower picture is a picture from a workshop we did on lung cancer stigma to really launch the campaign to end lung cancer stigma associated with the American Cancer Society's National Lung Cancer Roundtable. I do have some conflicts to report in terms of working on this lung cancer stigma issue with J&J's Lung Cancer Initiative, the Lung Ambition Alliance, and the GO2 Foundation. But I do have to say that, you know, I'm just a part of society as well. And occasionally the lung cancer stigma impacts my own thinking and processes, but do my best to remain vigilant and stay on top of those. It's an amazing time in lung cancer care and control. We have innovations that are transforming the entire continuum from those risk reduction efforts all the way through survivorship. And I won't go into the details, but it's simply a transformative time in improving outcomes in lung cancer. But that is all, our ability to implement those is all clouded by lung cancer stigma and nihilism that really hampers our ability to translate these effectively into our community. And that's a fundamental assumption that we operate on with regard to the role of stigma and nihilism in sustaining the trajectory of improved outcomes in lung cancer. And so we can look at it through the socio-ecological model of having repercussions at every phase. Jim Pantelis talked about yesterday about the policy and the lack of funding and the lack of heterogeneity of funding in various sources around lung cancer, that we do a nice job in some of the basic science and even some of our clinical trials, but beyond that with behavioral science and implementation science that has been a bit limited. And so part of what another fundamental belief that we have in the lung cancer community is that in order to make these changes, we really have to complexify and add richness to the societal understanding of the lung cancer story in order to prevent and mitigate the consequences of lung cancer stigma. As part of the National Lung Cancer Roundtable, we've developed a lung cancer stigma pathway model, and this was started in around 2018, 2019, and I'm really pleased that there's a lot of similarities with the health stigma and discrimination framework. And it's very validating, but we know we have quite a few causal factors that contribute to the experience of lung cancer stigma in society and in clinical care, and it has a host of consequences and hampering our ability to deliver all these innovative services that we have and improve outcomes. And in order to really change that lung cancer stigma, we both have to eliminate these causal factors, things that are generating, but also mitigate the consequences. We can't simply focus on one or the other in order to change this societal setting. And in many ways, we recognize that changing the causal factors is very much the long game process, but in the short game, we can really work to make sure that we're delivering these effectively as possible, taking into consideration the stigma context that exists in American society. We also draw a lot of inspiration from this amazing author and speaker and the TED Talk that she's presented. And I personally listen to this every 6 months or so, just to remind myself of some of these key principles about how stereotypes and simplifying our story can be a major contributor to the challenge. And so Adichie talks about the danger of the single story. But in many ways, lung cancer, I believe, is the danger of a double story. And really, the only societal perspectives and knowledge or foundation of information that we have around lung cancer that is pervasive in society is that it's linked and caused by tobacco use, and that the outcomes are terrible. And with these two prevailing understandings, if you combine that knowledge of the tobacco link with very aggressive tobacco control messages that infuse fear and stigma, you get an exacerbation and a pervasive societal context that devalues and others the tobacco using community, as well as the individuals who have been diagnosed. And if you think that the outcomes aren't good and there's nothing that can be done about it, and the inattention and limited research, you build the sister concept or the sibling of nihilism and fatalism. And the combination of these two things is really a destructive force in our ability to achieve optimal lung cancer outcomes despite these transformative innovations. But due to work and engaging the community, we realize that we have some resources. We have empathy and compassion that can really infuse in our messaging and our outreach to overcome the stigma. And we can share the optimism and the innovations that have come from industry, from science, to really help overcome that negativity and that fatalism. But we also have to recognize, both from the perspective of the advocacy community, but also the context that we currently have in lung cancer, is that we need to be urgent about this. This community has waited so long for innovations, and that these innovations are creating an opportunity to really change the way our entire society thinks about lung cancer. And this was really recognized by the American Cancer Society's National Lung Cancer Roundtable, and recognizing the centrality and importance of these three themes that can be used to really transform our societal perspectives. We launched the campaign to end lung cancer stigma through the roundtable to do work and develop a strategic plan that, first of all, leverages these themes to reframe lung cancer, to help expand our cultural knowledge and understanding of lung cancer, to complexify that understanding. In a mitigation attempt, we have to improve survivorship. Now, when we define survivorship, we even extend it all the way to promoting early detection more effectively with compassionate and empathic and optimistic messages. We also want to work with our clinician community to enhance an understanding and to infuse empathy into our clinical settings, And then finally, the fourth strategic aim is to amplify and expand research, to draw in more resources from our funding partners, but also to expand the portfolio to really, particularly with around the implementation science, because right now we are sitting on the mother lode of innovations that are transforming care in clinical trials, but not necessarily as robustly into our community settings, with a primary example being lung cancer screening. One of the things we're doing at a societal level with the leadership of Jill Feldman in the International Association for the Study of Lung Cancer was to develop a language guide to work at a societal as well as a research infrastructure level to change the way we talk about lung cancer, using person-first language, using patient-centered or person-centered approaches to really communicate effectively and to build bridges between the scientific and clinical and advocacy communities, and to put together this language guide that is also informing our other efforts. And we've also developed the idea of a lung cancer stigma biopsy. And this is the idea we can develop a set of stigma-free principles, assessment tools, and guides for implementing and delivering health messaging regarding that complex relationship between lung cancer and tobacco. We have some uncomfortable realities that tobacco use is the principal driver of lung cancer. And yet we need to figure out how to do that without blame and shame, to communicate that. So in working with our content creators, we wanted to recognize that language, imagery, and the context in which language and imagery are used really matter. And that we developed a process guide and introduction to inform the use of a language audit, as well as an alternative language guide for people who are developing a new pamphlet on lung cancer screening, or a new communications tool, a new campaign around biomarkers or things that to monitor and address, to make sure that language is supportive and compassionate. The imagery that we use, there's really no reason to use stigmatizing imagery around this. We have to work our way away from that fear-inducing, that stigma-inducing imagery. And finally, to present some understanding of how we use this and these imagery and language in the context really matters, and provide guidance to our content creators on how to do this in a more effective way. I also want to highlight some of the work that we've done as part of the Kentucky Leads Collaborative that has a more of a mitigation approach to addressing lung cancer stigma by working on survivorship care, and emphasizing the fact that individuals like Dr. Waters was talking about yesterday, and part of our failure to support survivors is due to stigma, and generates further stigma, and it inhibits our ability to transition a survivor into a survivor advocate, and to really, we have a robust advocate community, but it could be even more robust if we did a better job of meeting the needs of these individuals. And so we've developed what we call a precision approach to lung cancer survivorship, with a conceptual foundation built on patient-centeredness or person-centeredness, shared decision-making, and motivational interviewing to target and tailor an intervention to the unique needs of the lung cancer survivor. And we have emphasizing the survivorship engagement, recognizing that they deal with a societal context that stigmatizes them, but also shares nihilistic and pessimistic beliefs about their outcomes. And it really does not create an engagement approach. And so we want to encourage them. We want to provide support for addressing the physical symptoms that they face, and the psychosocial concerns, and any health behavior changes that they may be interested in making. But most importantly, this is all centered on their preferences. We present them a menu of interventions for them to choose from. We center them as the perspective that matters, not us as necessarily as clinicians or interventionists. So they choose the modules that they do, and we hopefully develop a relationship of trust in order to perhaps expand into other areas that may be causing them harm and impairing their quality of life. But in addition to that, in a multi-level sense, we also need to recognize that our interventionists or our healthcare clinicians are part of society as well and are impacted by stigma and bias and nihilism around lung cancer, even though they work in those environments. And that in order to help them overcome that, we developed a training program that really robustly helped them understand, as also explore some of their own biases in helping them deliver this intervention. So we like to think that we're creating an environment, in addition to the intervention delivery, creating an environment where there's a higher likelihood of achieving better quality of life outcomes, because we're helping the clinicians recognize those too. And we've evaluated this training intervention, and you can see here that this is one of my favorite slides, because I get to highlight only those, there's very few variables that were not significant in terms of participating in this training platform and improving their confidence to address lung cancer survivorship issues. There's only a couple of areas where we weren't able to improve their self-efficacy around working with individuals diagnosed with lung cancer over the course of their survivorship trajectory. Perhaps most importantly, though, we saw consistent gains in empathy and understanding of not just individuals who've been diagnosed with lung cancer, but actually experience not just cancer, but those individuals who diagnosed with lung cancer and have a history of smoking, as well as individuals who do not have a history of smoking. In terms of how have we infused stigma specifically into the intervention modules, one of our modules addresses distress in response to the cancer experience. And so we view lung cancer stigma as one of those potential stressors, and we've developed coping strategies to manage distress from that perspective. And we've leveraged heavily from the GO2 Foundation, formerly the Lung Cancer Alliance's work, on helping family and friends and individuals diagnosed with lung cancer recognize that they may be exposed to stigma. And we realize we walk a fine line between it's not your responsibility to address societal lung cancer stigma, but our belief is that we can help you mitigate distress by helping you prepare for if and when you do face this, and helping people have an understanding of how to address this and provide a way that's going to make them feel comfortable in that situation is better than leaving them unprepared to deal with this challenge. We also work with their caregivers and recognizing that these folks are in a difficult situation as well. As caregiving for individuals diagnosed with lung cancer can be quite complicated, just like other settings. Recognizing that the caregiver is dealing with external stigma, in some ways being a buffer, and preparing for that external stigma, but also managing some of their own beliefs about lung cancer and making sure that it's not as impactful as on them negatively as it can be. So I don't have outcomes yet for much of this research, except for the preliminary trial that we did, and it was a preliminary trial evaluating acceptability and feasibility of our intervention. And you can see that we were able to engage individuals, in contrast to previous studies we've done, individuals diagnosed with lung cancer and their caregivers, showing a pretty robust accrual portfolio. So in conclusion, addressing the causes of lung cancer stigma and mitigating its persistent consequences constitute a principal challenge of realizing all of the innovations across the entire lung cancer continuum, and that we've found that the socio-ecological framework has been informative to identify these opportunities, but also that we have much to learn from other stigmatized conditions and work in other areas that has already informed it. But I've learned so much over the past 4 to 8 hours in ways that we can hopefully adapt further interventions to address lung cancer stigma that can evaluate the efficacy and effectiveness, as well as implementation of these tools and strategies.
Thank you so much, Jamie. And I know I apologize that we've had to go through these presentations so quickly. You all, everyone who's talked at this meeting could have had an hour or two to themselves. These talks have been so wonderful. So I encourage more conversation in the chat. I encourage you all to follow up with each other. behind the scenes, because there's so much great work going on. We do have a few more minutes that we can engage for this panel in question and answer. And I'm actually going to take a question that came to Megan and see perhaps if everyone might weigh in on this. And so if everyone from the panel can turn their cameras on. The question was thinking about the type of participants that we recruit for videos or pictures and pamphlets, or to deliver our stigma interventions, for example, or the individuals who participated in the crowdsourcing. How do we think about the credibility of those individuals, and thinking about them being the storyteller and being a trusted source of, again, the story, the experience, their lived cancer situation, their, being an educator or a healthcare professional, just thinking about credibility and narrative and storytelling. So whomever, it was directed to Megan first, so I might let her take that. But then let others, again, with all the visual and audio work that you're doing in your different studies.
That is a really great question. And that's one of the things we want to get into, not just for the woman in the video, but for the peer navigators as well. So I think we often gravitate to whoever volunteers or who's available, but one of the co-investigators really has really wants to develop a way to figure out who has the motivation, who has the ability to provide the messaging, and who has the impact. And we didn't think about it so much for the video. The woman there is an actress, and she's phenomenal. And if you were to watch the video, she did it in all 3 languages. And if you were to watch it, she just has this smile that is so engaging. So we were lucky that our team had worked with someone who knew her, and we were able to get her. But one of the things that we're trying to probe with the focus group discussions of the women who watched the video to get this more specific content is how they related to her, or whether there were things that they would have liked to see, or different type of people they would like to see in the video, because it really is just her, and then there's a group of 3 women that she's talking with that occasionally ask questions. So I'd love to know if other people have other ideas of how they would measure her, charisma and impact.
Anyone, Tom or Jamie, thinking about the messenger and credibility? Thoughts? Chikosi?
Yeah, I'm not sure that I have particularly sage thoughts about the credibility. I mean, we had cast our crowdsourcing net quite wide to, and in doing that, the way that we had solicited lots of these solicited lots of these images was through organizations which were activist organizations, activist CBOs, and a lot of the people that already subscribed to their social media channels were people who were currently living with hepatitis B or hepatitis C. And so a lot of the submissions that we collected were people who themselves were living with chronic viral hepatitis and had personal experiences there. And then when they created materials, a lot of it was very kind of personal stuff about kind of where they were coming from, what they had experienced, how they themselves had had conversations with friends and family members or the wider community about their viral hepatitis status. And so whether or not that resonated with people, whether or not that gave them a sense of credibility, that I don't know. We didn't ask people. We unfortunately didn't have a qualitative component to assessing our intervention, which I think would have been super interesting. But at least to me, as someone who was like reading through those things, I was very touched by people being so open and honest in materials that would be disseminated nationwide through social media.
Jamie?
Robin, I did have some thoughts. Nothing that's particularly helpful, unfortunately, but the lung cancer community deals with this too. I personally am not a fan of direct-to-consumer marketing, but in this context, we've seen some of our industry partners around lung cancer go to direct-to-consumer marketing, and I feel like it has a normalizing effect of having lung cancer be part of the national dialogue for a couple of those prominent agents. That being said, and to address the point at hand, there has been given a great deal of grief about the selection of the individuals in those media campaigns. I mean, they look too healthy to have lung cancer. I mean, that's stigma. I mean, how are you supposed to look? And societal perspectives are really troubling when you see those things. And if my motivation ever gets low around lung cancer stigma, all I have to do is go to a public-facing story about lung cancer in any newspaper and go to the comments section and read that. It is heinous as to some of the societal things that people will say and propose in response. And that's part of our society and why we have to be addressing lung cancer stigma in order to achieve the outcomes that we have, and in other domains as well. But it just seems so toxic in the lung cancer environment.
I want to ask one question for all of you to respond to. You're all doing such innovative work, and thinking ahead to dissemination, thinking ahead to sustainability, thinking ahead to applying what you learn to different either cancer contexts or different infectious disease contexts, but taking that next step so that, again, we're not always reinventing the wheel. Does anyone have any thoughts, again, just thinking about the longer term of these different projects that you've talked about and where they'll go to next, and where we can think about that implementation and dissemination science angle as well?
So I'll take a first stab at that. With the work on what we're calling tentatively calling the stigma biopsy, we have borrowed extensively and looked at tools from other domains. Like there are lots of other guides out there that we found about health communications in a more compassionate, empathic, and non-stigmatizing way. So we have used some of those tools, but it is unsatisfying to be doing this on a case-by-case basis, when in reality, if we could engage the content developers more broadly, not just cancer, but all health conditions, that to eliminate blame language from our media campaigns and from the imagery that we use. But unfortunately, some areas are, I said it yesterday, that they're addicted to fear as a way to change public behavior, and they're not necessarily seeing our message. And it was also highlighted yesterday that if we only focus, and I'll signal out the CDC Tips campaign because I like to do that, as if you only focus on the fact that it drives more individuals to call the tip lines, that's a fundamental failure of science, because you're not studying the harms. If you only study the benefit, when was the last time we put a chemotherapy out on the market without studying its side effects? Never. It would never happen. And we have to understand both the benefits and harms of our interventions before we should be putting them out there. And yet we haven't necessarily adapted those principles in health communication and behavioral science in other areas. The other thing, Robin, is, we also talk about in terms of our mitigation interventions, designing for dissemination, and that's a very important concept. But we also have to design for acceptability and person-centeredness and fundamental understanding of the community that we're trying to serve. And that's why we can't take breast cancer survivorship interventions and just lump them on to other communities, because we have this robust literature. The lung cancer community is is unique, has unique assets and unique challenges. And so it has to come along the entire way. And so I think one of the themes from the day, from the past 2 days, has been a community engagement and an infusion of partnerships and co-design and co-creation that have to be part of this from the very beginning and throughout the whole process, through evaluation and interpreting in the context of community perspectives as well.
All right, I'm going to let Binda have the last question of the day.
Thank you so much for those very insightful presentations. I have 2 questions. The first one is to Dr. Jamie. And looking at what you've just demonstrated from a lung cancer perspective, and considering that often in our region, we tend to take and copy and paste some of the solutions that have been presented, what would you say would be the do's and don'ts in taking the learnings from what you've just presented into leapfrogging our advocacy journey, converting or sensitizing survivors into being survivor advocates? And for Dr. Megan, you talked about Western Kenya, and I'm quite familiar with your work, which is quite commendable and incredible, as it were. And I was wondering, how would you see your results that you're seeing in Western Kenya, where we have a high comorbidity of HIV and AIDS with cervical cancer, transferable to other communities within Kenya, for example, the nomadic communities, in terms of getting to the level of where we have so much investment in Western region to the nomadic communities in Northern Kenya? Thank you so much.
Megan or Jamie, whoever would like to go first, and we'll wrap up.
Well, I'll go first, Megan. Again, sorry, because so I've pilot tested this belief with the lung cancer advocates community, but I believe that the people who transition from survivors to survivor advocates in lung cancer do it because they don't want the future generation to have the experience that they did. Whereas in other cancer domains, I'm going to use a breast cancer example, where there's a community of support that rallies around them, that they're heroes, that they're champions, that they're, that really around them. They do it to pay it forward. They want the next generation to make sure that, that they have access to the same resources. And so those two survivorship trajectories are dramatically different. One's a pretty easy path from my perspective. One's a very difficult path from my perspective. And that's why we value the folks like Jim and Jill and just and Dusty and all the folks that really rally around this and try to bring more people in and to provide that support. And I hope that partially answers your question, but the other part of the translation is making sure that the communities can vet any of those ideas before they're translated, because they have to go through that community window and throw out the garbage that's not going to work for the community that you're working with, and highlight the stuff that will, and then layer on to the unique community perspectives.
Yeah, and I'll address some of the questions about, working in areas with different HIV prevalences and different cultural and social makeup. I think one of the things when Robin asked about sustainability, one of the things that we've really benefited from is I would say the success of the stigma reduction messaging and care delivery in the HIV care, in the facilities and the community-based care in Western Kenya. And it seems that women have really internalized those messaging. And what it looks like is that the lower levels of HIV-related stigma are probably driving lower levels of HPV-related stigma in the area. And so we're using that to our benefit, I think. And then, some of the health messaging that we're doing builds off, but some of it veers away from what is helpful in the HIV world. So we're really trying to focus on what's actionable, and may not, it may end up that knowing that, teaching women the epidemiology, the risk factors, the association with HIV are not actionable messages for them to get to make them decide to screen. So I think some of those principles we could translate, but what we would hope to have at the end of this is a toolbox, and people can pick what works in their setting and adapt it, and use some of what we have that works, but not sort of take it as a complete intervention. So in our setting, peer navigation is very popular. So how can we strengthen peer navigation? Who needs the, professionalism training? How can we develop that to make it more universal and reproductive health oriented? So in areas where peer navigation may be more tricky because of the, who would act as peer navigators and people's different privacy concerns, that might not be the way that intervention, that component of the intervention is translated. The video works for us because there's in the health facilities, there are often long waiting periods and limited number of people who can give health talks. So that there's, people are waiting and expecting some sort of health messaging. So that fit into that category. So I think, looking to see what is needed in the context and understanding, that population, working with that community to adapt or build new tools would be important.
All right, I want to thank this panel very much for their excellent presentations for this Q&A session. And again, I'll for the last few minutes turn back to Chad if folks have more to add. But now I would like to invite Dr. Bill Klein to join us. Bill is the Associate Director for the Behavioral Research Program at the National Cancer Institute. It's my honor to call Bill my boss. I have asked Bill to join us this afternoon to think about, again, what he has heard, what he has seen, what he has felt during this two-day meeting, and thinking about this, again, from his own background in psychology and his leadership in behavioral science and health communication, and to wrap up our two-day meeting with some concluding thoughts. So Bill, the floor is yours. And we can go a little bit after 1:30 if we need to.
Okay, I'll try not to abuse my time too much. Yeah, thank you so much, Robin. And thanks to Vidya and Katie. This has just been a spectacular meeting. I'm sure that everyone here agrees that it's been well worth the time we've spent listening to all these fabulous talks and discussions. So thank you for your efforts in putting together a really terrific agenda. I also just want to say it's really been fun to see a truly exceptional collaboration between our Division of Cancer Control and Population Sciences and the Center for Global Health. And for those of you who don't walk around the halls of Shady Grove with us, those of you who are not at NCI, you probably are not aware that NCI is a huge monolith. It's the biggest institute at NIH. So to have a division and an office at NCI work together on something, it's not fait accompli. It's not something that's just going to happen. It really takes work. So I want to thank my colleagues for making that happen so well. As Robin said, I'm a psychologist by training, a social psychologist. And so, I find myself making comments at lots of meetings in areas I know pretty much nothing about. But fortunately, this is something I do know a little something about as a social psychologist. I've been thinking about and teaching about stereotypes, prejudice, discrimination, and stigma for years. And so I've really enjoyed the last couple of days because I've learned a great deal and it's really enriched my understanding of these concepts. I want to make some observations, things that have been sort of rolling around in my head and perhaps your heads as well. And I've been following the chat box, so I can tell that we're on the same wavelength on some of these. Number one, we've been spending a lot of time at NCI and at NIH talking about misinformation and disinformation over the last couple of years. And you may be aware that we're about to come out with a major new initiative on health communication using common fund money, which is serious money. This is money that comes to NIH to address areas that really don't fit within the confines of one or more institutes. And it strikes me, listening over the last 2 days, that stigma has been an example of mis and disinformation for years. And we can learn a great deal from the stigma literature to help understand how to address misinformation. The notion that cancer is contagious, the notion that camel urine could be a cure for cancer. We've heard many myths over the last couple of days that need to be addressed, have been addressed, and potentially lead to methods that could be adapted in other areas of misinformation. Second thing to point out, and I think we all know this because we've seen it over the last 2 days, is that we can learn from other disease domains. Lots of work has been done in HIV, and that's fantastic. Also in physical disabilities. I think we can learn a great deal from understanding stigma in other domains, while at the same time trying to identify what makes cancer different than these other disease domains. And it is different in many different ways. And understanding those differences can potentially lead to effective interventions. Third point I want to make, and you're not going to be surprised to hear this from me as a social psychologist, is the power of social norms. I think we haven't really used that term much over the last few days, but a lot of what we're seeing here when trying to understand stigma is about social norms. I think back sometimes to a really classic study by Faye Crosby back in the 1970s, where she found that a high percentage of women in her sample said they had never experienced sex discrimination. Wasn't called gender discrimination back then, so that's why I'm using the term sex discrimination. But they nevertheless believed it was prevalent. And that was an interesting finding because there was this idea that I'm okay, it's everybody else who's not okay. And if you apply that to what we think about in this stigma space, you can imagine a lot of people thinking that they do not stigmatize others, but that all of their peers do. You can imagine being in a community, and we heard about this yesterday, a community where people do not believe that stigma is appropriate or positive or a good thing, but they believe they're in the minority and that they're not, that most people in fact stigmatize more than they do. There's a lot of more recent work by Emily Pronin showing that people generally think they're less biased than others, right? I'm not a biased person, I'm a fair-minded person. It's all those other people who are biased. But if everybody believes that, then there's something wrong. And that needs to be addressed. So there are lots of different social norms here and public norms that need to be addressed and understanding how to address stigma. A fourth point is that a lot of the work being done here, and this cannot be said for some other areas that we support, is very theoretically rich and methodologically rich. So for example, we have the Health Stigma and Discrimination Framework that Anne presented yesterday. There are a lot of areas of science, including work that we support at NCI, that could use more of that kind of framework, that organizing framework that helps us understand how variables are related to each other and how to address them. The methodological richness of this work is really notable. Hearing about crowdsourcing today, that was really a terrific example. Many different kinds of interventions, qualitative and quantitative research, multi-level approaches. These are all good things, things that potentially can make a difference. And mentioning multi-level raises another issue I just wanted to mention, which is that we do need to meet people where they are and in a multi-level way. We have heard again and again over the last couple of years that we can't just address racism by telling people not to be racist and putting through implicit bias classes. We need to address systemic racism, and that's the case here in thinking about stigma as well. We need to take a multi-level approach. I think it's notable that stigma rears its ugly head across the entire cancer control continuum, and we have seen that using many examples over the last few days. And in so doing, I think it's also notable to pay attention to the fact that it's not just the stigmatized that we need to address, it's also the stigmatizers, because both the stigmatized and the stigmatizers are all across the cancer control continuum, and they're affected in both negative and also positive ways. So we do know that people who are stigmatized experience depression and many other negative outcomes, including family tension. We heard yesterday that some cancer patients do not want to tell their family they have cancer, particularly if it's a cancer that's stigmatized. So there are all kinds of negative consequences. But there are also negative consequences experienced by the stigmatizers. And I think it's worth noting that as well. I'm reading a book right now that many of us in our division are reading for sort of a book club discussion called The Sum of Us by Heather McGee. And she talks about the fact that tension between Blacks and whites has really led to this perception of a zero-sum game, that there's one winner and one loser. And she talks about many examples of how that has not only had negative effects for Blacks, but also for whites, such that the entire culture, the entire society has been brought down. One of my favorite examples in the book, and I was thinking about this over the last couple of days, is that back in the 1950s, many communities developed huge town pools that people could swim in. It's a great opportunity for families to get together and experience, the social capital that comes with being together with others. And that turned out to be a problem because they were only open to white citizens. When there was a move to make them available to Black citizens, the white citizens said, no way, we're not going to do that. And what happened? They closed down the pools. So the pools got papered over, and they don't exist anymore. Now we have much more in the way of small pools, small private pools. And that's particularly true around the Washington, D.C. area. And my family has belonged to one over the last couple of years, and I never realized that history. But that's an example of how stigmatizers and those who are stigmatized collectively all lose in the end. And it's something I think that we really need to understand. And Jamie, the book is The Sum of Us by Heather McGee. Really interesting book. I've enjoyed reading it. Last couple things I wanted to say. One is that it's patently clear that we need to be thinking about intersectional stigma, just in the way we need to think about intersectional identities and stereotypes. We all have multiple identities. We're not just fathers, we're not just mothers, we're not just sisters or brothers, or stigmatizers, or people who are prejudiced, or people who are prejudiced against. We're a whole slew of identities. And all of those identities need to be brought to the fore to help understand what the impact of stigma might be. I'm really taken aback by some of the fascinating work that John Ruiz and others have done, looking at what's called the Hispanic paradox, which finds that Hispanic populations, even though they tend to look worse on many health outcomes, tend to be better on other health outcomes. And the explanation is because of the social connection that they have, and the culture that really fosters social connection, and how social connection can buffer them against the effects of negative health outcomes. That, to me, is a great example of how multiple identities all come together in a way that produces a soup that we need to better understand. Last couple things to say. One is this has been a hot topic in the chat, particularly recently. Health messaging. Should we be using fear appeals in health messaging? Should we be using stigma in health messaging, which goes one step beyond that? And should we acknowledge the effects of all of these messages on the way in which people are perceived? We need to do something better about that, right? We need to advance beyond fear appeals. We need to take advantage of the really well-evolved health behavior change literature that many have contributed to over the years. Particularly, I want to highlight Susan Mickey's work in the UK, her behavior change wheel, which has identified many different types of health behavior change interventions that could be leveraged. And also want to note that it's possible to use positive messaging. I want to mention smokefree.gov, which is a tool that we're heavily involved in working on and in seeding over time. This is a tool that is used by smokers to help them quit, and it's all based on positive messaging, self-affirmation. You can do it, and you can get support from others to help you do it. And this is based on research. It's all evidence-based, but it's not about stigmatizing smokers. It's about giving them the tools to succeed. There's also a lot of recent evidence that smokers who engage in healthy behaviors like physical activity and healthy diet can also benefit greatly from that. Some recent data that have come out in leading journals showing that that's the case. So worth paying attention to that as well. That's positive messaging. The last thing I just want to say is that you should all be in touch with us. We are not just, as one of my colleagues used to say, we're not just ATMs that give out money for grants. We are scientists who really care about advancing the science using all the tools that we possibly can use at our disposal. And that, of course, includes funding opportunities. And we have many that are related to stereotypes, prejudice, systemic racism, et cetera. I also want to point out, though, that we have data sets you can download. Our Health Information National Trend Survey has many items that are related to the experience of trying to get information about cancer and cope with information about cancer. And there are some themes there that are related to stigma. We have a number of tools. I mentioned smokefree.gov and many other tools that one can have access to. These are all public access tools and data sets. And we have many training opportunities as well. Katie Healy herself, one of the planners of this meeting, is a cancer prevention fellow, a postdoc in a really stellar program we have here at NCI for postdocs who want to get a master's in public health and then get cancer training internally. And she is one of many fellows we have in our division. And I encourage those of you who have graduate students, to encourage them to take a look at our postdoc opportunities, because it's just really a nice opportunity to see how the sausage gets made here at NCI and how we think about our priorities. So take advantage of those training opportunities and all the other tools and opportunities that I've mentioned to you. We're here to help and we want to hear from you. So again, thanks for the opportunity. Sorry we went over here, and I will turn things back over to Robin.
Thank you so much, Bill, for those comments and for you've inspired even just again all the references and different resources that you mentioned, the different research literature. So thank you again for those reflective remarks. I believe we have one more slide that we want to put up before we close. And again, we want to say thank you to everyone at NCI who's been part of this conference, all of our speakers, all of the attendees, everyone joining us from all four corners of the world, our IT partners who have helped us run the show. Again, thank you everyone who has helped us organize this behind the scenes. We are really grateful. We specifically want to thank our fellows. Again, Bill just mentioned Katie's involvement in leadership of this two-day workshop, and behind the scenes, we had 4 other fellows helping us with note-taking and recording and contributions to the conversation: Dr. Naomi Green, Dr. Yuki Lama, Dr. Margarita Perez Mendez, and Ms. Abigail Muro as well. So again, thank you to everyone who has helped us host this meeting and contributed to the wonderful conversation. And we look forward to continuing this. This is just the start. I think that's the whole point of doing this work, is that we want to go forward. We want to do more. We want to keep the conversation active. We want to have opportunities for our extramural community. And we promise that this is just the beginning. So with that, we will wish you all a very happy afternoon and a good weekend.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.